questions போட்டுருக்காங்களான்னு தெரியல எனக்கு.
இது
கீழே கடைசி வரைக்கும் வாங்க.
ஒரு நிமிஷம்
வேண்டாம் அதை Chennai 2022.
Calcium phosphate, which is
Okay.
You can share that screen itself. Session 3. See whether
ஒரே நிமிஷம் அந்த காப்பி
Session 3.
செஷன் 3 3 already when I saw
And we need all the slides in that laptop. Just a second. Okay. Because it's not going to go there. So that it's easier for you all to move the slides from So you want to stay. So this is the chat.
okay
This is mine. You also need to have this is updated. I just did.
செஷன் 3 already when I saw என்னோட ஸ்கிரீன் போடுங்க
So this is so the first is mine. I just did. This slide is mine.
அந்த
Is it coming? No, I don't think so. Echo la edu undalla.
இது இங்க கேட்கும்.
Yeah. I don't think there's a echo.
அதுல வருதா?
The voice is coming there. No problem. So for first one day, I've already opened the PPT and kept. Okay. Arpana Jyoti இருக்கு இல்லையா அதை ஃபர்ஸ்ட் நீங்க ஷேர் பண்ணிடுங்க. செகண்ட் PPT நான் ஓபன் பண்ணி வச்சிருக்கேன் so that it's easier for you. Okay. Next is Meenakshi tune வரும். Okay. So that is also opened. So அப்போ வந்து Zoom ஆன் பண்ணிட்டு ஃபர்ஸ்ட் அவங்க CV இன்ட்ரோ듀ce பண்ண பிறகு நம்ம ஷேர் பண்ணும்போது you can go and share one next to two. Okay, got that.
ஸ்பீக்கர் ரெண்டு ஸ்லைடு வரலாம் பேசுறாங்க.
ஒவ்வொருத்தவங்க மாறி மாறி அவங்க வரும்போது you just have to help them.
Okay.
So அது பண்ணிட்டு camera is already on, keep it on.
Good morning to one and all gathered here. We'll be hosting today's session. We have few important announcements for the day. There will be online polls or quiz in between the sessions. There's a keypad attached to each of your table. You can vote using the keypad when questions are being displayed. The options will be given as 1, 2, and 3. There will be a dedicated 10 minutes slot at the end of each session to address the questions from audience. Now we'll move on to the scientific session. First session of the day is nutritional assessment. Nutritional assessment of children with CKD. I invite the moderators, Vanessa Shah and Dr. Uma Ali, to the stage. Vanessa Shah is a honorary senior lecturer, UCL Great Ormond Street, Institute of Childhood, University College London, UK. She is head of dietetics at Great Ormond Hospital Street for Children, London until 2017. Her specialist clinical area was chronic kidney disease in the underfed children. She was made a fellow of the British Dietetic Association in 2007 and was awarded a national honor and NDE for services to the Children's Hospital Care in 2008. She is a reviewer for pediatric nephrology and Journal of Renal Nutrition and co-chair of the Pediatric Renal Nutrition Task Force. She is the editor of Clinical Pediatric Dietetics, the seminal text for pediatric dietitians in the UK and overseas, now in its 5th edition. She established the unique MSc in Pediatric Dietetics, a partnership degree between the British Dietetic Association and the University of Plymouth, UK, where she was an honorary associate professor until January 2021. Dr. Uma Ali, she is consultant pediatric nephrologist. Her present affiliation is Lilavati Hospital and Research Center, Mumbai, SRCC NH Children's Hospital, Head of Nephrology, Jupiter Hospital, Thane, and founder Kidney Foundation for Children. Her major achievements are former Dean of B.J. Badia Hospital for Children, former head of Pediatric Nephrology and PICU, B.J. Badia Hospital for Children, Mumbai. She has established acute to chronic dialysis services at BJWHC and pediatric transplant services at Lilavati Hospital. Her publications were in Asian Pediatric Nephrology Association, and she was awarded 9 orations, including the prestigious P. Ridani Oration and Lifetime Achievement Award by IAP Pediatric Critical Care Chapter. She has more than 60 publications. I request the moderators to introduce the speakers. She is under the corporate position. Young, dynamic, pediatric nephrologist. She's best known as
Thank you, Chairperson. Dear colleagues, delegates, welcome to you all. It's wonderful to be here because I don't know how many of you know, it's the first time we as meteorologists are meeting up with our issues on a professional platform like this. And it very close to our lead, Dr. Susan Govindan, and the mention from Dr. Susan Shaw from the University of Children's Hospital and Mehta Shaw. So we will start off with a very basic field training that has helped us all understand nutrition care in children with kidney disease, and that is assessment tools, how to assess nutrition status. Before we do that, it would be nice to get to know our audience. So I see so many young faces here. We'd like to know how many of you take care of patients with kidney disease. Show of hands, please. Good. 1/3 of them. How many of you look after children with or without kidney disease? Okay, 1/4. So the rest of you are more familiar with adult care in general, right? Okay. So it's important to know this because we are diving into kidney disease in children, but we need to keep this in mind that please let us know whenever you feel that you'd like us to clarify more, because we are talking about not only these children but also kidney disease in children. And we hope that these 2 days will be impetus for you to understand and have getting more enthusiasm to learn pediatric renal nutrition as you go along, as you grow in your own respective careers. I am
Good morning, everyone. So for today's talk, I'll be presenting the case, and I request Dr. Arpana to give her inputs in between. So the overview of my talk would include growth in a child normal versus chronic kidney disease, dietary evaluation, anthropometry, biochemical parameters, and other assessment tools. So it's important to know how a child actually grows till he achieves the final adult height. So as we can see in this chart, on y-axis, we can see the percentage of total height achieved in a child. So when the child is born, he has already achieved 30% of his final adult height. During the phase of infancy in first year of life, the nutrition plays a crucial role, whereby the child attains 50% of his adult height, followed by childhood where growth hormone has a role, and in pubertal phase where the child attains his final adult height with the help of sex steroids and growth hormone. So normal growth and development are the central goals in the management of any child with chronic kidney disease. So nutritional adequacy plays an influential role in achievement of these goals. So how does a child who has chronic kidney disease differ in his or her growth pattern as compared to a normal child? So we can see in this graph, the shaded area shows the growth of a child who is growing normally, the lower dotted line representing the 3rd centile and the upper line as the 97th centile. So in the lower red dotted graph shows the growth of a typical child with chronic kidney disease. So in the infancy phase, if a child has CKD, infancy phase is the phase where the child grows very fast. So if there is nutritional component plays, and as we know, nutritional component plays an important role. If there is poor nutrition, it will lead to severe growth restriction. And in childhood phase, the growth is comparatively steady, but in CKD, there can be delayed attempt of the childhood pattern or the resumption to the infancy pattern, thereby leading to growth restriction. Also, there can be delayed onset of puberty, and the pubertal spurt might be
slow in itself, thereby leading to final short stature in these children. So in addition, if the nutrition gets affected in these children, it leads to severe growth restriction. And we know poor growth is associated with mortality and decreased quality of life in both children and adults. So the measures to maximize nutrition in all these phases is very important. And as the puberty is the phase where the growth spurt mainly occurs, it's tightly linked. So assessment of pubertal development is as important. So we'll take the assessment of nutrition with the help of this case, who is a 10-year-old boy with posterior urethral valves and grade 5 reflux. So for the benefit of dietitian, posterior urethral valves is a form of congenital obstruction at the bladder outlet, which is associated with some renal dysplasia, which later can, despite the surgical correction, later can lead to chronic kidney disease. So this child was surgically managed in infancy and was lost to follow-up since 4 years of age and was taking some homeopathy treatment. Later, he presented at 10 years with seizures and tachypnea and was found to have weight of 14.2 kilograms and height of 102 centimeters, and serum creatinine was 11 milligram per deciliter. So if we look at this child who is a 10-year-old, just by looking, he doesn't look like a 10-year-old child. He looks like somewhere around 5 to 6 years of age. And with this CKD stage 5, he was initiated on CAPD. So how do we assess nutrition in these children? So the component include dietary assessment, anthropometry measurements, biochemical parameters, appetite, taste, and smell assessment, and finally the nutrition focused physical examination. Different dietary assessment tools include dietary recall, whereby multiple 24-hour recalls can be taken from the parents and asked about the diet of the child. Then we can have prospective minimum 3-day diet diary, which should ideally include a weekend because that can have different diet during the weekend. And then there's food frequency questionnaire. I won't dwell much on this as the next speaker will be talking in detail about it. More important is the frequency of dietetic contacts with these children should have. So as the PRNT guidelines suggest, it should be more frequent in the advanced stage of CKD throughout the ages. And as we know, in infancy nutrition contributes to the major growth. It should be frequent in the infants. Coming to anthropometry measurements, we have weight for age, height for age, mid-parental height, height velocity, body mass index, weight for height, and head circumference. In subsequent slides, we'll cover each of them. So just, I would like to know from the audience, if you can just let us know which chart do you use for plotting the growth in a child. So there is a World Health Organization chart. Yeah,
There is a key pattern attached to each of the chairs. So based on your question number, which is main that you are originally don't worry, your answers will be also. So this means it comes.
Okay, so I think majority of them have opted for 49% for the WHO charts, and almost equal for CDC and IP, and 25% have opted for all of the above. So, ma'am, would you like to?
So I thought all of the above would be the choice in maximum numbers. So Are you familiar with CDC charts and you know what IAP stands for? Yes? Okay. So Indian Academy of Pediatrics is a regional group chart. So the question was, which of them would be relevant to children, and actually all the three are relevant. It depends on what nomogram, what anthropometric measure we are looking at, and what is available. And as you will see in the guidelines, the BRIC guidelines, that regional growth charts, if available, should be used. So it would be nice if you are anyway familiar with WHO, but IIT growth charts also would be a good option to use.
So the PRNT guidelines suggest that up till 5 years of age, we can use the WHO or World Health Organization growth charts, and CDC charts can be used after 2 years, or if you have country-specific charts like Indian Academy of Pediatrics charts, which we have, we can use them too. So coming to the different anthropometry measurements, weight for age. So it's very important to plot the dry weight in a child with CKD, because there are different disorders like nephrotic syndrome in which there can be edema per se, or a child can be fluid overloaded who is on dialysis. So it's important to consider their dry weight, that is edema free weight. Similarly, there can be some tubular disorders where these children are prone to tubular losses of fluids and they can be dehydrated. So that might underestimate their actual weight. So as we discussed, WHO charts till 2 years, and country-specific charts later should be used. Then there are certain disease-specific charts for diseases like Turner syndrome and Prader-Willi syndrome, because these children don't grow like any normal children. They have a different growth pattern. So when we are plotting growth for these children, those charts should be used. And special mention about children who are premature, who are born less than 37 weeks. In them, the corrected gestational age should be plotted. So let's say a child who is born at 34 weeks and you are evaluating him at 2 months of age, the corrected gestational age for that child would be actually 1 month. So that should be kept in mind while plotting the growth for these children. Coming to height or length for age, it's very important to plot or measure the height or length for this child. There are different methods to do it. For children who are less than 2 years, a length board should be used. Ideally, 2 persons should be used, one to steady the head at the head end, which is fixed, and the other person to keep the feet perpendicular to the plane of the body, and the length can be measured. For children who are more than 2 years and are able to stand, the occiput, the shoulders, the buttocks, and the heels should be touching the wall. We should keep in mind that they should not have any cap or hair accessories while we are measuring the height. Certain children can have associated contractures where it's very difficult to get the height as well as the length. We have certain surrogate markers like arm span or ulnar length, which can be used in these children. Once you have plotted the height of the child, it's important to also determine the mid-parental height, which we'll come to later, because it helps to estimate the growth potential for the child. The formula for calculating the target height is addition of mother's and father's height. And in case of boys, the figure of 13 is added, while for girls 13 is subtracted and is divided by 2. And the target height range is calculated by this value plus minus 8.5 centimeter. So I would like to ask the audience, this is not a keypad question, but which of this child do you think has a short stature? A 3-year-old boy who has a height of 82 centimeters, and we can see it's the height if plotted on the growth chart is denoted here. And the second child who has a 4.5-year-old boy with height of 95 centimeters. So any answer from the audience? Who thinks A is short stature, or okay, who thinks B is short stature?
Show of hands.
Show of hands.
Raise your hands.
And A?
Any other answer? Okay, we can.
Yeah, so I think we did hear the answer. So both are short stature. So this is to bring about the point that WHO has 2 types of charts, which is percentile charts and Z-score charts. So anything below the -2 standard deviation is short stature, as well as when we plot a growth on percentile chart, both children are below the third centile. So both children have short stature. So this is just to bring about the point of different charts developed by WHO. Coming back to our case, this is his growth parameters 1 year later with dry weight of 15.1 kg and height of 112 centimeter. And this is what we have plotted on the Indian Academy of Pediatrics growth chart. We can see that both height and weight for this child is less than third centile. So now for plotting the target height for this child, the mother's height was 152 and father's height of 172. So can I ask the audience to calculate the target height? So it's, yes, I heard someone giving the answer. Would anyone like to answer this? I heard 168.5. So the target height, according to the formula, comes to be 168. And if we see the range, it comes to 160 to 177 centimeters. So this is here where the target height of the child lies. And we can see he's not actually growing according to his potential, which he would otherwise be growing. Coming to the concept of height age. So what is height age? The height age is the height of the child, which will lie at the 50th centile for a particular age. So for this child who is 9-year-old, 108 centimeter actually lies at, we can see, at 5 years of age. So his height age would be 5 years. So we'll see in our subsequent slide how knowing the height age is important in regards to plotting of the body mass index. So coming to the concept of height or length velocity, this is the same child whose height is denoted at different period of time. And this is the growth velocity chart. Here we can see again emphasizing that maximum growth is in the infancy period, which growth velocity is during the earlier age, which decreases subsequently just before the puberty. And during puberty, there's a pubertal spurt. So calculating height velocity, we need two heights at least at the interval of 6 months. And the value is subtracted and divided by the period of time in which the two value points were obtained into multiplied by the months in a year. So for this child, it comes to 24/6, which is 4 centimeters per year. And it's calculated, as we can see on the y-axis, the growth velocity is calculated by centimeter per year. While plotting the growth velocity for this child, it's plotted as 4 centimeter per year. So it determines if the growth rate for that particular child is appropriate for his age. So we can see subsequently, once the child was initiated on CAPD, at least the growth velocity is not falling, but hope so it gains further if we obtain the height in subsequent years. Coming to the concept of weight for height and body mass index. So it denotes the appropriateness of weight relative to height, because we know that the children with CKD have short stature. So we can underestimate their weight if we BMI, if we plot it in relation to their chronological age and not the height age. So in children less than 2 years, we use weight for height, and for older children, body mass index. So it's calculated with this formula, weight in kilogram divided by square of height in meters. And BMI for height or length is used to determine the Z score or SD score when the child is shorter than third centile and has not achieved his or her adult height. So while knowing body mass index is important. So I'd like Dr. Arpana to comment on this.
So just to give you all the relevance of body mass index, when it is lower than normal and when it is higher than normal, then we have a problem associated with mortality. So a malnourished child with low BMI and the overweight or obese child, both these extremes of BMI are associated with mortality. So that is the relevance of interpreting the BMI.
Thank you, ma'am. So as we saw, we need to plot weight for height or length for a child who is less than 2 years of age. So here's an example. A 14-month-old boy with CKD stage 3 has weight of 6 and 72 centimeter. So if we see on x-axis, we have length or height in centimeters, and on y-axis, we have weight in kilograms. So for a length of 72 centimeters, when the weight is plotted, it comes much below the -3 Z score for this child, thereby showing that this child is severely undernourished. Now coming back to our case who is more than 2 years, so we need to plot BMI for this child. So I would like to ask the audience, which would be the correct plotting for this child? So his BMI is 12 kg per meter square. So is the A correct or is the B correct? Okay, by show of hands, anyone for A? Can't see any hands. So anyone for B?
Is the question not clear? So what's the difference between A and B? We're trying to incorporate the height age here because the child is short, right? So that's the key message. So according to that, now can you choose between A and B? B.
Yeah, so here the A is plotted according to his chronological age, which is 10 years, which show the BMI much below the third centile. While if we plot it according to his height age, we see that it is just lying at the third centile. So plotting the BMI relative to the height age will avoid the inappropriate underestimation of the person's BMI. So this, the earlier chart was the BMI chart developed by Indian Academy of Pediatrics, which is available for more than 5 years. And this is the CDC chart for BMI, which is available for more than 2 years, which can be used for plotting the BMI. Coming to the next anthropometry measurement, measuring head circumference for children up to 2 through 3 years of age is important. Coupling to it, we should always assess their development. So the correct way of measuring the head circumference will be to keep the tape just above the supraorbital ridge and posteriorly at the maximum occipital prominence. So measuring at the same visit thrice will avoid the underestimation or overestimation of the head circumference. The only disadvantages in case of a child who has hydrocephalus, we cannot actually consider head circumference to be a marker for nutrition. I would like to ask Dr. Arpana about the significance of mid-upper arm circumference.
So if you have noticed that we never mentioned about midarm circumference as an important anthropometric measure in assessing. But as pediatricians, we are all aware that midarm circumference is important for us to know, especially in children less than 5 years of age. So in children with CKD between birth and 18 years, midarm circumference is not a mandate, but it is useful in as a part of a criteria to diagnose an entity called protein energy. Since most of you are caring for adult patients and adult nephrology patients, you must be familiar with this term protein energy base. So it's a criteria there, and it's also a criteria used to define safety. I don't say that it is not useful. If you are familiar measuring midarm circumference, you can go ahead, but interpretation is important, and you must use the right charts to interpret midarm circumference, especially by and then you can also derive the mid-arm muscle area from midarm circumference, because as you know, midarm circumference is incorporates both subcutaneous tissue and the muscle. So if you want only the muscle part of it, then you have everything that can be derived.
So as ma'am has already alluded that we have different arm circumference charts, again developed by World Health Organization for children from 3 months to 5 years of age and different for girls and boys. So now coming to the next keypad question. So what will be the recommended frequency of monitoring height for age in the previous case? Just to remind, he's a 10-year-old boy who has CKD stage 5 and is initiated on peritoneal dialysis according to PRNT guidelines. Yeah, so I think majority of them have answered it correctly, which is every 3 months. So the PRNT guidelines suggest the different frequency of nutritional assessment in children with CKD. As we can see from this chart, it's more frequent in children with CKD 5D. Weight for length is not applicable more than 3 years, and head circumference is also applicable only till 3 years. So a child who is young or has a severe stage of CKD needs more frequent evaluation of his nutrition and anthropometry measurement. Then appetite, smell, and taste alterations in children with CKD can lead to specific eating behavior patterns. So there are certain tools which can be used to assess these parameters. Amongst this, 5-point scale for appetite was studied in a CKD study where it was assessed as very good, good, fair, poor, and very poor. And it was found that anything apart from very good was associated with more morbidity. Then there are other tools like picture-based assessment and visual analog scale, but it has yet to be implemented in routine practice. Coming to the biochemical parameters, serum albumin was considered as a strong predictor of clinical outcome in children on dialysis, but it is affected by many other factors like fluid overload, protein losing diseases like nephrotic syndrome, and it's a negative inflammatory marker. And in case of associated liver disease, the albumin can be low per se. So the guidelines state that serum albumin should be utilized as a nutritional marker only when other non-nutritional causes of hypoalbuminemia have been ruled out. Now, in short, about normalized protein catabolic rate, it indicates daily protein intake, and the guidelines suggest that it should be used in children, in adolescents who are on HD, and the value of more than or equal to 1 gram per kg per day is indicative of adequate dietary protein intake. Though for an individual child, it can provide information. If the trend of the NPCR can provide information pertaining to their weight gain and dietary protein intake. I would like to ask ma'am about the other parameters.
So just to also let you know what is not really useful in terms of writing the parameters, that is serum transferrin and serum cholesterol. You must have heard of these two biochemical parameters because they are recommended in the diagnosis of protein energy based especially. So this is not found useful in terms of detecting undernutrition or protein energy based. Another word about normalized protein catabolic rate. How many of you actually are familiar with this? Do you do it in your patients and practices? No? Okay. Just to give you in a very simple way, we look at what is the rise of urea, pre-dialysis and post-dialysis, and divide that by the number of hours between the two dialysis sessions. So that gives us a ratio, as she said, more than 1 gram per kg per day would be good. But if it is somewhere around 0.6, that means that the patient is undernourished. So that is only relevant in patients, adolescents especially, on hemodialysis. And it is not really useful in other patients who are not on hemodialysis or who are on perineum.
So coming to the other keypad question, I would like to ask the audience, what do you think is this image depicting? Yeah, it's a keypad. Okay, so I think majority of you have answered it correctly. So it is showing the severe degree of muscle mass loss, which we will be talking in the next part. So coming to the nutrition focused physical examination, which has 3 parameters of evaluating potential areas of muscle and fat loss in different areas and presence of non-nutritional edema. So this basically helps us to corroborate our medical nutritional history, which we have obtained from the parents. So these are the different areas where we evaluate for loss of subcutaneous fat, that is facial cheeks, the area of biceps and triceps, the ribs, and the buttocks. So coming to each of them, so we can see in this child who has a full round filled out cheeks is well nourished, while a child who has a flat cheek can be suggestive of moderate malnutrition, while a severely malnourished child will have a hollow cheek. Coming to examining the biceps and triceps area, so 2 fingers can be used to pinch the fat stored between this area, and the space between these 2 fingers will show the amount of fat which is present. So here in this figure, we can see that some space is present between the fingers, suggestive of moderate malnutrition. Coming to area of ribs, we need to evaluate the lower back, as in this patient, and in the mid-axillary line. As we can see in the figure, the depressions between the ribs are clearly visible, and the ribs can be clearly delineated, which is suggestive of severe malnutrition. Coming to evaluating the fat in the buttocks area, so a well full round buttock will suggest a well nourished child, while a flat buttock will with slight curve but not completely round will suggest a moderate malnutrition. And in case of severely malnutrition, we have a typical baggy pant appearance where we can see the wrinkled skin in the buttock area, suggestive of severe malnutrition. Then we need to evaluate different areas for the presence of muscle wasting. So these areas include clavicle, shoulder, scapula, thigh, knee, and calf. So in clavicle, as we can see in this image, the clavicle is really prominent, and we can see the depression just above the clavicle, which is suggestive of severe malnutrition. With the arms bent on the side, we need to evaluate for the deltoid muscles, and we can see the bony prominence is clearly available and the joint appears squarish, which is suggestive of severe malnutrition. And the image which was depicted before, the scapular border is clearly visible. We can clearly delineate the whole scapula, again suggesting the severe malnutrition. Similarly, other areas need to be evaluated for the presence of muscle wasting. Coming to presence of nutritional edema, in a child who is ambulatory, the presence of edema can be checked in the ankle or on the dorsum part of the foot, while if the child is not really ambulatory, looking at the sacrum and pressing on the sacrum is important to look for the presence of edema. So here in this child, we can see by pressing on the junction of the anterior and middle 1/3, a pit is clearly seen, suggestive of edema. But again, emphasizing the fact, before a child is labeled to have nutritional edema, it is important to rule out other causes of fluid overload or other causes of edema. So now I would like to, in short.
It's difficult to, it's easier said than done because most of the time we may not aware of the child. If you're looking at children with metabolic syndrome, probably the mother would say that the baby was so before the child started to have it. But in children who are on dialysis, it's difficult unless you let the child experience some kind of hypotension and symptoms of hypertension during dialysis, and that's what you see the diet. Or the blood pressure will be very controlled, and then you decide that this could be the diet. So just to give you a good to know point, I don't know if you actually use this device called bioimpedance analysis. Do you have? Yes, I expected that. So because we use it quite commonly in adult patients. So just to let you know that the body weight is made up of many compartments, and what we are concerned in patients with CKD is the total body water. So the tissues are hydrated, and we got to know what is the driving weight in these patients. So we have derived something called bioimpedance vector analysis. So this is a graph. So this is a graph where this is a bioimpedance analysis device, and the next slide please. So this is a graph where you see that there are 4 quadrants: dehydration, overhydration, increase So if you look at the graph on the right hand side, you see the shorter arrow is actually showing that the patient is in overhydration. The child who's on hemodialysis. And over time, with each session, we are doing more and more here. And then we monitor these patients post-dialysis to achieve the point which shows within the circles that you see there. So that is like control, that is the reference curve. So the points should go within those reference curves. So this is one way we have found it very useful in practice, especially in dialysis patients, not so much in peripheral dialysis patients. And that is one objective way, easy, non-invasive way to target gyrating this patient.
So to summarize the overall nutritional assessment of a child with CKD, dietary assessment is very important and should be the first tool before any other causes can be attributed to the poor nutrition of the child. Anthropometry measurements, as we have seen, measuring them correctly and plotting them on chart to see the trend, to see the growth of the child is important. That includes estimating the dry weight, weight for height, height length for age, height velocity after infancy, mid-parental height, body mass index, head circumference in child less than 3 years, and mid-upper arm circumference. And as we have seen, in terms of biochemical parameters, serum albumin should be considered as nutritional marker only when you have ruled out the other causes of hypoalbuminemia. And normalized protein catabolic ratio should be used only in adolescents on hemodialysis. And nutrition-focused physical examination is a useful bedside tool to evaluate for different potential areas for looking for loss of fat, muscle mass, and presence of edema. So anthropometry measurement, as we have discussed, should include all these parameters and should be plotted on appropriate growth charts. Nutrition-focused physical examination is an important clinical tool, and more frequent assessment of nutrition should be done for children who are young and those with advanced stages of CKD. And PRNT guidelines are very useful aid to help in regular assessment of children with CKD. Thank you.
The nutritional assessment forms the basis for all evaluation, which and now we want to
Very good morning to one and all here. At the outset, I'm truly grateful to Dr. Sukanya Govindan ma'am and Vanessa ma'am, as well as Dr. Rukshan Ashraf for conducting a session, an eye-opener session and a workshop for the practicing dietitians. So many of us have been handling CKD adult. Very few of them have been handling pediatric CKD here. not only in South India, but throughout the country. And truly grateful for the hands-on experience from all those who have been well-versed in handling pediatric CKD. So I won't be selling ice to the Eskimos, but since it's a very structured program, forgive me for going into the basics when it comes to dietary assessment. So when we talk of assessment, basically without nutrition assessment, we cannot go about with nutrition intervention. All of us are aware of this fact. And the time we spend on nutrition assessment, most importantly, the time a dietitian spends is on the dietary assessment and recall. Based on the recall is only we can put up the nutritional PES, that is the problem, etiology, signs and symptoms. Followed by that, we plan the goal and then the intervention. So without the complete dietary recall, it's like traveling in a very bad weather in a stormy sea with no compass on hand. So that's the basic background when we talk of dietary assessment. And as our previous speaker very beautifully illustrated the entire nutrition assessment, I will try my best to put few important points when we take a dietary call. So obviously in nutrition assessment, we talk of screening. First, we need to screen the patients, followed by nutrition assessment, then dietary intervention, monitoring, and evaluation. So when it comes to dietary intervention, already our former speaker has made a mention that we do a 24-hour recall. Either it's a food diary or it's a food frequency questionnaire. Last but not the least is the assessment of smell and taste. So when it comes to nutrition care process, we need to understand it's a very structured approach, a very systematic approach, which has been established by the Academy of Nutrition and Dietetics, based on which we identify, plan, and meet the nutritional needs. So it's a systematic and accurate collection of data, which allows the caregivers a process to determine whether the interventions are effective in improving or resolving the nutrition diagnosis. So when we talk of nutrition assessment, obviously our former speaker has given us the details of it. But now when it comes to the dietary recall, it is one of the most widely used tool in nutrition epidemiology to identify food, energy, and nutrient intake. I would be talking not only with specific to pediatric CKD, but when we talk of dietary recall, it's used majorly in national nutrition surveys, cross-sectional studies, clinical trials, cohort studies, evaluation of individual dietary intake, which we do in our IP and OP, as well as the total diet assessment. So a 24-hour recall is basically a retrospective method of dietary assessment where an individual is interviewed about their food and beverage consumption during the previous day or the preceding 24 hours. How long does it take for us to do a dietary assessment? Can anybody just have their show of hands and tell us? A detailed dietary assessment, just a 24-hour recall, takes how much time? 5 minutes, 15 minutes, or more than that? Can we have a little louder answer? At least 15 minutes, especially in a CKD patient, wherein we need to spot and find out if there is hyperkalemia. Why is there hyperkalemia? We can have one particular patient, hardly eating anything through the day, but still there could be hyperkalemia. Then we can relate it and see whether it's associated with the diet or no. Or is the patient constipated? That is why there is hyperkalemia and the dietary recall shows hardly 200 calories as the consumption. Now, when we see hyponatremia, in fact, you would have seen in most of the CKD patients, early when the parent comes and meets you and you're trying to tell them salt is to be restricted, fluid, sodium, potassium, phosphorus, you confuse the parent totally, disturbed the parent, and the parent is worried as to what I need to feed my child, right? So she thinks that it's best to put my child salt-free. So that could be one very vague reason for hyponatremia. We could have another way out is the mother is worried that there is periorbital edema, there is sometimes body anasaka, and we have, unfortunately, our neighbor, vegetable vendor, milkman to newspaper person, everybody telling the parent how to remove the extra fluid, not realizing that this is CKD, how we can help the child. You know, the mother is complaining and saying, my child is having edema. She doesn't understand edema, but she says there is a lot of fluid which is sitting in her ankle. So how do I remove it? So we have a lot of home-based therapies, which are neighbors and unfortunately even our grandmothers and people at home try to make those advices, which could be one of the reasons for the hyperkalemia, which could be one of the reasons for hyponatremia because of fluid overload. So a dietary recall has lot of importance in planning our intervention and at the end of the day, even the prognosis of the patient. So interviewee is very, very important, and interviewer. Now interviewer, suppose she or he is speaking in a language which the interviewee does not understand. The purpose is lost. I think we are doing a very shortcut method, just I would say namesake interview, which is of no use. I think you might as well not do it. So it's important that the communication method could be of appropriate to the interviewee. If it is inappropriate, the purpose is lost. The age, sex, educational and cultural level, degree of involvement with food and nutrition, their recall capacity. All this plays a very, very important role when it comes to the factors affecting determining a dietary recall. Interviewer. Now, suppose I have a very new dietitian. I wouldn't say new dietitian. She's just finished her graduation. She's not had enough exposure in handling patients, and she's been put in the OP, you know, just to observe, but then she's trying her level best. You know, she still wants to take the recall because she's very enthusiastic. She wants to take a recall. And if I've left her in the OP with the patient's caregiver, to be very honest, she may not do a very good job, because what she's read in theory is totally different from, you know, pulling out the information what we want for the necessary intervention. So if I'm unable to pull out the information I want, my job is like shooting arrows in the dark. It's of no use. So it's important that the interviewer has some prior training, and most importantly, she should be patient. If she's going to be in a hurry, I'm sure she cannot get the information we want. She should have specific training for the project, level of commitment. Yes. Most importantly, she should have the passion to help the patient. If she's not passionate, then she's not going to do her job well. It may not be part of our structured UG or PG curriculum that she needs to be passionate, but this is a part of handling patient care. We have no choice on that. Quality and adequacy of interview support tools. Now, unless and until you have plate models, because each one's house chapati size is different, katori is different. In India, that's a very, very big challenge, what all of us go through. Person does not understand what is a teaspoon and a tablespoon, what is 100 ml and what is 200 ml and 250 ml. But these small nuances make a very big importance when it comes to dietary recall. Coding system and computer software, I think it's only the very few high-end institutions which have access to this. And as our former speaker very clearly and beautifully told us about how we can get onto the dry body weight and the velocity, we need to understand that how many of us have access to this. Yes, for research, it's amazing, and high-end institutions do have this, but so many of us do not have access. So what do we do then? So we need to find smaller methods also, in addition to understanding what are the high-end equipments which can give us the best of information. Food and beverage composition table. Beverage composition is very, 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 very important, because when it comes to CKD children, they are used to carbonated beverages, they are used to Tetra Pak juices, they are used to proprietary drinks. So, and you know, it's like, I'm sure all over the globally, a mother is happy when the child has had a big glass of milk. You know, if the child has not had a glass of milk, at least add some proprietary drink or one oral nutrition supplement, so that the energy and the nutrient is enhanced when the child is taking a very compromised diet. So what are the advantages? Advantages of a 24-hour recall is, as I've been mentioning to you in the past few minutes, that without this, we cannot move forward. But it's a retrospective method, and usually the consumption is not altered. Since the mother, most often it's the mother, sometimes it's even the father who's sitting across with the dietitian. Why would they want to give a false information? They want the child to be helped to the best. So they will very rarely give you an unaltered or false information when it comes to the diet recall. Serial recalls definitely help you in a better way. And administration does not require much time. I wouldn't agree to that. Though this is what the publication says, but I would say you need a lot of time when it comes to recall, and it improves with increased number of 24 hours dietary recall administered in the same study subject. It can be administered to low literacy populations, yes. But now I would want to make a note or a mention of it is, it's nice to read in a publication that a telephonic interview will do. Believe me, nothing like a face-to-face. Even today, after we have gone through the pandemic, a lot of consults happen over Zoom call, over video call, over conference calls, but nothing like a face-to-face. Even if we've had a Zoom call or a video call, the parent insists that, madam, when we can come and have a face-to-face interview. In the face-to-face interview, we can judge and see whether the patient's attender is giving us the right information or no, and what else we can probe to help the patient better. Now, validity of the tool. It is considered as a valid instrument for the assessment of energy and nutrients. Now, it's important to understand, suppose I'm taking a recall and the patient has told me I've had some sambar rice. Okay. Now, my next question is, the sambar was made with thick dal, with thin dal. Were the vegetables added to it? Did you have an accompaniment like a fried papad? If the child was, more than 16 years of age, then did she have an add-on pickle to it? So what are the little things which she consumed in that small sambar chawal, what the child has consumed? What are the limitations of a 24-hour diet recall? Extensive dependence is on the recent memory. Now, if I'm going to get a one-day recall, once again, I'm not getting adequate information. Suppose the patient is going on dialysis. I need to know the non-dialysis diet recall. Just excuse. A non-dialysis recall and a dialysis recall. Apart from that, a weekend and the weekdays. If the child is going to school, school days and off days. And if there are religious festivals in between, I need to know that also. So it depends on interviewer's capacity for describing the ingredients. Now, it's very important. You may find it very silly for me to say this. I would say the best cook would do the best job as a dietitian. We are not glorified cooks. I would want to make that clear. A dietitian is not a glorified cook, but believe me, her understanding in cooking is good, means she will understand the ingredient in the recipe the child has consumed. If she doesn't understand that, yes, through reading books and, nowadays YouTube gives us a lot of information on recipes. But it's nice that if you're interested in cooking, you'll be able to do a better job when it comes to a recall and when it comes to calculation of macro and micronutrients. Now, I've had so many young girls, when they come to me as interns, we tell them, okay, a porridge. Now they'll say, ma'am, we can make 100 ml of porridge with 50 grams of flour. You cannot make 50 grams of flour to prepare 100 ml porridge. This is the basic understanding which a dietitian needs to know for her to interpret what is the ingredient used and finally what are the micro and macronutrients present in that recipe. Food and beverage consumption, as I mentioned to you, there is a controversy when it comes to understanding the volume of the beverage. One single 24-hour dietary recall does not estimate the usual intake. So it's important. We have to move a little further, and it's even more difficult for the mother when she's so disturbed, depressed about her child, and also financial commitments are very, very high, for her to sometimes give you the entire recall in the past 3 days. The planning of 2 or more 24-hour dietary recalls complicates the field work, requires well-trained interviewers, both for face-to-face and telephonic administered interviews. So what are the other limitations? One important thing which I learned over this was the flat slope syndrome. In the flat slope syndrome, we understand two things. Either there could be an underestimation or there could be an overestimation. Now, if the mother is feeling not very comfortable or the father has come over, he does not know what actually the child has consumed the previous day and he's embarrassed to tell the dietitian that I do not know what my child has consumed yesterday. He may just give one vague estimation of what the child has consumed, which may have no relationship to what the child has consumed. The quality of data obtained via interviews is frequently limited by the lack of adequate food composition database. Thankfully, in India, we have Indian food composition tables by IFCT 2017, which is a comprehensive, database of the Indian food ingredients. However, a single 24-hour recall is not considered to be representative of habitual diet at an individual level. But one needs to understand the way we are getting ourselves updated today. The food composition table has been updated way early, 1999 and now 2017. So there are some health professionals who do not update themselves regularly and they still sit with the concept that a guava is considered as low potassium, whereas it is really high in potassium. So these things are important, like how I think Dr. Sukanya has made a real, I would say, too much of effort to bring all the dietitians and nephrologists together to update ourselves so that we can help our patients to the best. So this methodology is adequate for serving intake in a large group and estimating group mean intakes of diet. What are the recommendations and procedures to reduce error and bias? The first recommendation I would say is have So just before this comes up, I would say if I want to recommend and say in order to reduce the error and bias in our diet recall, if we can put down a checklist. When we put down a structured checklist, we wouldn't miss out on what we need to ask the patient's caregiver. That should be the first thing. And second thing is if we carry the models with us. As I mentioned to you, our katori, plate, chammach, all the sizes are different in India. I would say even my neighbor and me will prepare different size idlis, different size chapatis, different katori, which I have for the sabzi or the dal, what I'm serving, everything is different. That's a little difficult when it comes to India because the dal which you make in your house and the dal which I make in my house is also different. The sambar is also different, or you can call for anything. Hardly we meet a standardized, I would say, a standardization of recipe. It's nice to only learn in food service management that we've done standardization of recipes, or probably a restaurant or a hotel will offer you a standardized recipe. But I think in India, with reference to any recipe, even the simplest of recipe you pick up, there is less standardization. So first thing is, if you could have standardized recipes on hand in order to ask the patient, like for example, in an idli, some people use rice and urad dal 3:1, 4:1, 5:1 ratio. Some people add sago to it. Some people add old cooked rice to it. So we need to ask our questions very clearly, only if we know the various recipes used to prepare one recipe. So have available elaborate interview support materials. If you cannot carry a model, a photograph, various serving sizes, volumes, plates, foods, ingredients of recipes, prepared food. The use of different size models improves the reported answers. The data collection via specialized software. I think we are a little distant from this as yet for now, for the present situation. But still, this is an option which we need to keep in mind. If we have access to a specialized software, I know in Mumbai, Hiranandani works paperless. So they are to the level where even Ambani Hospital and the Reliance hospitals, they work paperless. That much I know. So those hospitals, when they are working paperless, they moved into software, and there you are ensured that you have not missed anything at all. But I think the same thing, when it can go into a soft copy or a hard copy, we can plan accordingly. So data collection via specialized software that directly carries out codification improves the quality of information obtained
allows for increasing the number of food codes, reduces the possible errors. This is more for research purpose. Utilization of novel technologies for data collection and processing. So now I'll go on to a recall of a 6-year-old child with CKD so that we get little more understanding as to where the problem lies when we take a recall. So we have a child who's 6 years old and so we have a child who is 6 years old and there is care of feeling weak, history of oliguria in the past 1 week with pitting, pedal edema and facial puffiness. She was diagnosed with CKD stage 4. She had a nil family history. When it comes to subjective data, appetite was normal, hunger satiated, thirst normal, bowel normal. Micturition was oliguric, sleep was disturbed and non-refreshing. Her height, we have her height, expected weight, weight. But if you look at the weight and expected weight, it's almost the same. So as a dietitian, you need to think that somebody with CKD stage 4, will she have expected weight? So that should give you the second thought that in my recall, I need to dig and find out, is there fluid overload? Because she's already presenting with pitting edema. So our work begins here itself with reference to diet recall. We don't have to wait for the recall to remember what question definitely needs to be asked. Obviously, we have the dry body weight calculation and the BMI will definitely be, not the ideal BMI if you're going to calculate with the present body weight. That's why the dry body weight. So in places where we do not have the BIA, we use the rule of 5, 10 and 15% to deduct mild, moderate and severe fluid overload based on International Journal of Transplantation 2012. So we have the biochemical data which tells us there is anemia, azotemia, hyponatremia, hyperkalemia and metabolic acidosis. When there is metabolic acidosis, we need to remember that the patient needs to go plant-based with reference to protein and a Plado diet, that is a low protein diet in order to reduce metabolic acidosis. This is only the dietary part of it. I am not talking of the medical management. So there is anemia, and when it comes to anemia, most mothers, they love to provide the patients with dates. And we all need to know as dietitians, it's only the dried dates which are sources of iron. And we cannot consume 100 grams for us to, correct the anemia. It cannot be corrected with dietary intervention. It has to be corrected only with erythropoietin. So that is important with reference to our recall. What are the food ingredients which they would add in order to correct the anemia, which actually cannot happen. Then in hyponatremia, as I mentioned to you, we need to worry whether it's the salt intake or salt-free diet, or it's the fluid overload. Only then think of correction with salt. So this is the usual dietary intake for this child. Can somebody just pinpoint and tell me which is the biggest flaw in this diet recall, which I have shared across? Can you spot? Yes, please. No measurements. Yes. So this recall is equivalent to not taking a recall. So it's not going to help me in identifying what's the macronutrient intake, what's the sodium, potassium, phosphorus, and fluid intake. So I need to go with measurements. So this is an approximate recall, what the mother gave, saying this is what my child eats on regular basis. And she eats varied every day. So I cannot give you a consensus of what she's eating actually. So now if I'm having in the morning, she's taking some proprietary drink, I need to ask her how much volume of milk and how many scoops of the energy supplement she's using. So that will give me an idea as to, is there fluid overload? Is the phosphorus and potassium coming from the milk or is it coming from the nutrition supplement? Now the breakfast is oats or ragi porridge. We need to remember that when we talk of leaching, we cannot leach a millet. And how do we leach a porridge? And is she adding milk to the porridge? Is she adding cut fruits or is she topping it with nuts? All these small things should come into my mind when I'm taking the recall. Bread with garlic butter Is it already some focaccia bread, or it's a regular bread, salted bread, wheat bread? Now parents are very anxious, it's the earlier days, sometimes they have missed the bus, and when the child has been identified or diagnosed with CKD, they become very, very health conscious. I've chosen on a multi-grain bread. Multi-grain is more healthier than the regular refined flour maida bread. So the multi-grain bread also could be the reason for hyperkalemia and hyperphosphatemia. Now the omelette, is it prepared with egg white or is it prepared with whole egg? The whole egg, the yolk, the battery is running now. The pongal is served with coconut chutney, groundnut chutney, sambar. Along with that was a vada served alongside. Maybe the child would have had only 2 spoons of it. Or maybe the child actually ate a decent portion of pongal because she loves pongal. Was it the sweet pongal which has got jaggery and cashews in it? Or was it the regular ven pongal? What did she consume and how much she consumed? Puri with potato masala, was it made with refined flour, with wheat flour, or multi-grain flour? We have no idea. Cornflakes with chocos and milk. What was the milk used? Nowadays, a lot of families are moving into vegan. So is she using almond milk? Is she using any other nut milk, soya milk? What is the source of potassium and phosphorus or the protein for us? Then comes to the mid-morning snack, wafer or cookies. What are the cookies? Is she taking, the cashew cookies or oat cookies, multigrain cookies? Dairy Milk, Kinder Joy, Choki Choki. Excuse me for putting these names, but this is what a child's recall was. So I thought I need to make a mention of it because cocoa is a source of potassium. So maybe the child has not eaten anything for breakfast and concentrated only on the dairy milk because the child likes it and did not mind consuming that than consuming the breakfast. The bisi bela bhat, otherwise made out of dal and plenty of vegetables. Was it served with aplam? Was it served with pickle, with papad? The dal rice, curd rice. Curd rice, did it have pomegranate on it? What was it served with? Was it prepared from millets? Because now it's become fashion to serve curd rice prepared from millets. But millets cannot be strained or leached once again. Egg fried rice, was it prepared with soya sauce, chili sauce, tomato sauce, vinegar? What was added to it? Was it purchased outside or was it prepared at home? Did they add some monosodium glutamate to it? All these details have to go into our recall for us to help the patient. Mid-evening cheese sandwich or French fries or plain cheese cubes, Cavan's milkshake, lime juice. Now simply say lime juice. Did she add a few drops of lime juice or did she have really a glass of lime juice? Was it with salt and sugar or was it with soda? That's how she prepared the lime juice. Then dinner was appam with kurma. Was it vegetable kurma? Was it chicken kurma? Did she add khaskhas to it or did she add coconut to it? Pasta and noodles and weekly twice, apple, banana, pomegranate. Did she have the whole banana or did she have the pomegranate in the form of juice? These little things will help us identify how much the patient has consumed. So with the understanding of the volume and the quantity she has consumed, we come to understand what is the calorie intake. And if the calorie intake is not meeting the requirement, the total energy requirement, definitely we expect PW, as our former speaker did make a note of it. But understand, whenever we go processed, always processed foods are rich sources of phosphorus and potassium, and the hidden words could be sodium. It could be some additive or a garlic powder, iodized salt. The list is long. But you need to understand, you need to go into the food label for us to understand where the sodium, potassium, phosphorus is coming from. I have 2 more case studies, but I think due to paucity of time, I will stop with this. But we need to understand that a diet recall is the backbone for any nutrition intervention. Otherwise, we are actually shooting arrows in the dark. Thank you so much for your patient listening. Yeah, yeah. இந்த என்னோட பிபிக்கு திருப்பி போங்க. இது க்ளோஸ் பண்ணுங்க. You do it. இது அடுத்து. சொல்லு. Yeah. So the first question would be, leaching process reduces dash content of the food ingredient. So we have the right answer with us, 57% potassium and phosphorus. Can we leach non-vegetarian foods? Yes. We can leach chicken.
We can make chicken.
Fish is difficult.
என்னோடது வேண்டாம்.
Fish is difficult.
But obviously we do not suggest.
Obviously, we do not suggest.
And egg whites, so we don't
And
need.
whites, so we don't even know, so we are not going to use that.
So we need to remember for those patients or
We need to remember for those patients on.
we need to put a lot of protein in them. And if they are non-vegetarians, we can allow them bleached chicken. Egg whites, obviously, yes. So that's another way of incorporating the phosphorus component. Obviously, we have the plant-based protein. But when I'm talking of the high biological value protein, that is the chicken or the egg whites. Insensible fluid losses in children and adolescent, you will calculate. So when we say urine output plus 500 ml for an adult for the obligatory losses, for children we say urine output plus, is it 500 ml per kg per day, or is it 120 ml per kg per day, or is it 20 ml per kg per day, and add on plus whatever they've lost through either vomiting or diarrhea. We need to replace 20 ml per kg per day. It's not 120 ml when it comes to the pediatric population. So daily fluid restriction is insensible fluid losses plus urine output plus amount to replace the additional losses minus the amount to be deficited, and the insensible fluid losses children and adolescents is 20 ml per kg per day. This has nothing to do with recall, but I thought these questions were of great importance for the dietetic fraternity in order to understand when we talk of fluid for the patients.
So we can have a correct way of life. So children of 5 years of age, they are connected residences like wildlife and so should be even a plastic group. So children above 5 years of age. Important question. So the challenge is a very good and the cellulite even there like chocolate salad and very high. So that the cellular are not as significant, but I think that's the way to see. So that should be. Yes. Thank you.
Good morning, everyone. I invite Dr. Kannan, Dr. Pranav Mehta, Dr. Rukhsana Shroff, Manasa Shroff, Dr. Edwin, Dr. Sudha, and Dr. Suganya Ma'am to the dais. We now have the inauguration ceremony for today's program. I now request all the members and delegates to rise for the Tamil Taiwan. Please be seated. I now invite Dr. Kannan, Group Medical Director, Mehta's Hospitals, to deliver the welcome address.
Good morning to you all. அனைவருக்கும் இனிய காலை வணக்கம். I'm immensely happy that Dr. Mehta's Hospital, in association with ISPN, ISN, and IPNA, is organizing this wonderful program of CME and workshop on pediatric renal nutrition. A topical topic about knowledge of which is very essential for the large number of delegates who are gathered here. I have been given the pleasant task of welcoming you all. First and foremost, though he is not here, my reverential welcome and pranams to Professor Nammalwar, father of pediatric nephrology in this part of the country, was instrumental in establishing Department of Pediatric Nephrology in Dr. Mehta's Hospital. He was ably assisted later by the late Professor Dr. Vijay Kumar, who is no longer with us and whose soul will be lurking somewhere around the auditorium, bless us all. The mantle then fell upon the triumvirate represented by Dr. Suganya, Dr. Sudha, and Kalevani, who are doing an able and commendable job, and the able guidance of the tall statured man, Dr. Edwin Ferrand. First and foremost, I welcome the honorable professors, the esteemed faculty, Professor Dr. Uma Ali, nationally renowned pediatric nephrologist from SRC Children's Hospital, our friends from across the globe, Dr. Ruxana Shroff from Great Ormond Street Hospital for Children, Madam Venisha Shah from Great Ormond Street Institute of Child at London, UK, Madam Meenakshi Bajaj from Tamil Nadu Government Multi Super Speciality Hospital, Chennai, India. Our warm welcome to distinguished faculty from all over India who have come here to impart knowledge to us all. I welcome Professor Edwin Fernando for again leading this conference, and I compliment Dr. Suganya Govindan for her wonderful organizational abilities, for choosing the right topic for the right personnel and toiling hard to organize this conference. I've been seeing her for the past 1 month. He was very meticulous in organizing this. I welcome the entire department, faculty of the pediatric nephrology department. This conference would not have been possible but for the initiative of the Mehta family, represented by Mr. Dilip Mehta, our benevolent chairman, our vice chairman, Mr. Samir Mehta, and Dr. Pranam Mehta, our dynamic director, who has been a constant source of inspiration for all our academic activities. Last but not the least, I welcome you all delegates who come from different parts of the country to gather knowledge. Let knowledge and wisdom come to you from every side. Let noble thoughts come to you from every side. Asato ma sadgamaya, tamaso ma jyotirmaya, mrityo ma amritamaya. Om Shanti Shanti Shanti. From darkness to light, from untruth to truth, from mortality to immortality. Let there be peace, peace, and peace. Let the knowledge that you gain be of assistance to the lovely children that you are going to encounter in your day-to-day practice. And let the light of wisdom spread across the entire breadth and length of this great country. Jai Hind. Thank you.
Thank you, sir. Every great occasion that shares academic light starts off with one of our oldest traditions, the lighting of the lamp. I kindly request all the dignitaries on stage to do the honors. I also invite Dr. Kalaivani, Deputy HOD, Department of Pediatric Nephrology, Dr. Meenakshi Bajaj, and Mrs. Bala, Head of Dietetics, to join us on stage. Thank you, sir and ma'am. I now invite Dr. Sukanya, consultant in pediatric nephrology, to give a short introduction to today's program.
A very good morning to all of you. I'm really delighted that all of you could come today despite the inclement weather, and all of you have turned out in large numbers. So thank you for coming. And I will quickly introduce you all to the objectives of today's program and what is it that we are trying to do. We all know that pediatric chronic kidney disease is a complex condition and very difficult to treat. Although we might all discuss about fancy treatments like dialysis and transplant, unless you get your nutrition right, nothing is going to change. So that is the hard truth that all of us should understand today. And although nutrition, I think, is probably one of the single most cost-effective treatment for our children with kidney disease. And if we fail to recognize that, we might land up in trouble and all our objectives and clinical outcomes are not going to be met. In India, and of course in many parts of the world, unfortunately, there is poor access to a renal dietitian or a nutritionist, and often the person giving the nutritional advice is a nephrologist, who again, unfortunately, is poorly trained in this aspect. So in this context, it is amazing that in today's meeting, we could all gather as a group of dietitians, nephrologists, administrators, and also we have patient representatives. In fact, all the stakeholders who have a stake in renal nutrition are present in today's meeting. So that is again one of the best things to do, I think. And today's meeting is a culmination of almost a year's work as a team. It started with having two stalwarts in the field of pediatric renal nutrition on board with us as mentors. It is Dr. Rushana Shroff and Vanessa Shaw. They are the coordinators of the Pediatric Renal Nutrition Task Force, and the group's recommendation and dietary resources are a major step in bringing best practices in this field to the whole world. And with their help, we are now in the process of adapting their work to suit Indian needs. And shortly, we will have resources available, Indian resources available for all of you to refer to. I should say Vanessa is the backbone of this entire exercise, and she's been amazing support to all of us. So a round of applause. And I should thank especially Rushana Shroff for steering us in this pathway and showing us the lead that this is the way that Indian CKD patients are going to benefit. It's not going to be only dialysis or transplant. Nutrition should come ahead, much ahead of all these two treatments. She's also been an amazing mentor to me. And I should thank both Rushana and Vanessa for their immense contribution to improving renal care in this part of the world. So a round of applause to both of them. Moving on, there are some resources of the PRNT group that you might all find in the website betaflow.org, and they're also freely available to download. So please use these resources. Particularly for today and what today's meeting and tomorrow's meeting is going to be about, I would like to congratulate the Indian team who has put a year worth of effort into this. These are our dietetics group, and they have been selected, handpicked from the length and breadth of India. They're all present here. Again, a round of applause for the tremendous work that they've done. It was not at all easy, and I can't tell you how much hard work has gone into this. I also would like to welcome and thank all the nephrologists that are part of this team. Again, from the length and breadth of India, they're all stalwarts in themselves. I'm very thankful that they could spend their time for almost a year in producing these nutritional food guides. So again, thanks to all of you. Particularly for today's meeting, I have a lot of people to thank for. Start with our director, Dr. Pranav Mehta. He's a clinician himself, and I know he understands how important nutrition is. And he's also steering our organization towards patient-centered clinical outcomes. And we also have our dynamic and youthful director, Dr. Kannan. And thank you, both of you, for making today's meeting. And I also have my wonderful nephro team, pediatric nephro team and nephrology team, including my mentor, Dr. Edwin. I can't thank them enough, and I'm very fortunate to be working daily with them. Finally, the pillars of this show, Mrs. Angel, Ms. Tamil Chelvi, our IT team, Mr. Arul and team, they've been struggling with Wi-Fi dropping throughout the auditorium, and that's the reason for the shutdowns that you were seeing. Unfortunately, it's not in our control. Apologies for it, but do expect some more problems with that. And also our facility team, Mr. Murli, the transport team, and also our support staff. I would also like to thank the sponsors for this meeting, IPNA, ISN, and our pharma sponsors. Thank you so much. And in the next 2 days, our goal is going to be not only learn best practices, but also initiate dialogue about how best we can cater to renal nutrition in our particularly vulnerable patients. And I hope we achieve that in the next 2 days. Thank you all for coming. Thank you very much.
Thank you, ma'am. No academic event is complete without an address by our beloved Dr. Pranav Mehta, Director of Mehta's Hospitals. I now invite Sir to address the gathering.
My dear friends, welcome. It gives me great pleasure to welcome you here to this great collection of minds organized by Dr. Sukanya and the rest of the pediatric nephrology team at Mehta's. It also gives me great pleasure to invite you to learn from this amazing event. The incidence of pediatric ESRD has been increasing, presumably because of lifestyle factors, and increased reporting. And the fact that we are able to learn about the importance of nutrition, which is a simple, applicable lifestyle factor that can make huge strides in the quality of life and improvements in the quality of life for the patient, makes a huge, huge difference. It's like lighting a lamp in dark void, and it gives a lot of hope to a lot of people. So welcome. I hope you learn. I hope there's going to be a lot of knowledge shared, and I hope that you'll be able to translate a lot of this into your practice, both clinically and outside, here in Chennai. And for those of you that have come from further afield, far away, and maybe some of you will find yourselves using this knowledge further afield. So welcome and thank you.
Thank you, sir. Next, I invite Dr. Ruksana Shroff, Professor of Pediatric Nephrology, Great Ormond Street Hospital for Children, to address the gathering.
Thank you very much. It's a great pleasure to be here. For many years, as a pediatric nephrologist, I used to be invited to give talks on dialysis, and I deliberately start each and every talk with an introduction about nutrition. I know I irritated a lot of people with that, but I think little by little, I perhaps made people aware that you cannot do good dialysis or good CKD care without good nutrition. So I'm so glad that we have now culminated in this event where all of you from all over the country have come together to discuss renal nutrition. It's absolutely crucial. I learned a great deal about that from my colleagues, Professor Leslie Rees, Sarah Lederman, and Vanessa Shaw, who really were the backbone of renal nutrition at Great Ormond Street. And I'm delighted we can take this forward now. We've thanked everyone here except Sukanya, and I think she needs the biggest round of applause. So Sukanya has really taken this forward. She has really taken up the idea of how important nutrition is and really run with it and made this event what it is. And Sukanya has done everything from organizing the program, the website, and even our most wonderful meals and dinners here. So thank you, Sukanya. Thank you for bringing everyone together, and thank you for taking this idea forward. I'm delighted that you're all here, especially all the young ones at the back. I hope we can inspire you all and make you future pediatric renal dietitians. Thank you.
I invite Dr. Pranav Mehta to felicitate Dr. Ruksana Shroff. Thank you, sir and ma'am. Next, I invite Vanessa Shaw, Honorary Senior Lecturer, UCL, Great Ormond Street Institute of Child Health, to address the gathering.
Hello, everyone, and I must say how delighted I am to be here in India, my first time here. And I've just had a lovely 10 days traveling around Tamil Nadu, and I hope that I'll be able to come back again to see more of this fantastic country. Thank you very much to Sukanya for inviting me to come and speak today. I am just going to echo some of Rukshana's thoughts that I think it's a wonderful event for us to be able to bring dietitians and doctors together, perhaps for the first time at this event. We've been very used to working very closely together, and in our clinics at Great Ormond Street and in the UK, doctors and dietitians work together in the clinic so that we can learn from each other and exchange ideas, and it's so much more beneficial for the patient to see both the doctor and the dietitian in the same interview rather than seeing the doctor first then being trundled off to see the dietitian. And I hope that as we start to expand our knowledge of nutrition, we can also perhaps change practice here as well. So it's great to see students here and dietitians who are perhaps dealing with adults. Perhaps you'll be enthused to become pediatric renal dietitians to get the training that's necessary to work alongside your medical colleagues so that we can really lift the profession of dietetics up in this country. I have to say, I've seen nutrition come on leaps and bounds whilst I've been working for over 30 years now. Some of you probably weren't born when I started looking after kids with chronic kidney disease. But I can say that when I first started work, we would see kids who had achieved the age of 16 or 17 going off to adult units, and they'd be the size of 10-year-olds. And that is because their nutrition had been neglected right from the word go. But over the years, we've developed a nutrition program. Everybody has recognized the importance of a good food, good diet. And so we're now getting these kids to start to grow pretty much normally. And when they have been transferred to the adult units, they can really enter the adult world, not having the psychosocial disadvantage of being extremely small. So this is a great opportunity for us all to celebrate nutrition and to keep it going. Thank you.
I invite Dr. Kaman to felicitate Manasa Shah. Thank you, sir and ma'am. I invite Dr. Edwin Fernando, Head of Nephrology, Mehta's Hospitals and Government Stanley Medical College to address the gathering.
Good morning to all. Nutrition plays a very important aspect of management of patients with CKD, more so in children, because the disease itself stunts their growth and plays a very important role. Nutrition plays a very important role in upliftment of these children, the quality of life, their growth after transplant, etc. To address all these issues, nutrition is a major problem in our country because one is the scientific facts are not very clearly known to even people who are at the helm of affairs. Second is the amount of money that needs to be put into to nourish this child or even the adult. So nutrition is a major cause of mortality in dialysis in our country, not only in adults, understandably more in children also. So I must appreciate the efforts taken by Dr. Sukanya along with the Dr. Rukshana, Dr. Vanessa, and our national faculty. I'm happy to see Dr. Manisha, Arpana, Arpita, Dr. Mali, Deepti, all of them who have joined together to come here to educate all of you, to enrich our knowledge, and also carry forward these to the most deserving. The end user is the patient's family and the children. So I wish you all a pleasant stay at Chennai and a happy learning over the next 2 days. Thank you.
Thank you, sir. I now invite Mrs. Mary Ann Manasseh, Communications Director, Kidney Warriors Foundation, to deliver her talk on patient perspectives in renal nutrition.
A very good morning to one and all present out here. It's indeed a pleasure for me to be here and represent the work done by many people across the country. But to give you a brief introduction of who we are as a foundation, KWF started with a group of small patients who connected on Facebook in the year 2015, there was two groups, one which was the kidney warriors and two, the diet for kidney patients. The Kidney Warriors today has grown to be called the Kidney Warrior Foundation, which is the largest patient advocacy group in India that has the vision to empower every patient to access of knowledge, awareness. We work with caregivers, counseling, financial help, changes in the government policies. We also work a lot with preventive measures. Well, we have a lot of work that we do on that side, but today I'm here to speak on one of our proud areas of specialization, which is renal diet. This is like a little story that I'm actually going to take you towards. It all started off in the year 2017 in the city of Bangalore, where we had a group of nutritional specialists who wanted to specialize in renal diet, along with the top nephrologist in Bangalore and the KWF senior members. The renal dietitians had to present to the nephrologists and the senior members of the Kidney Warrior Foundation on diets recommended on different stages of chronic kidney disease. And some fantastic work was done by the renal dietitians, and it was so fantastic that we decided to put this together and launch our book itself. But when we started working on these diets, we came to understand it's so scientific. How do we educate the patient to understand what we're trying to say? Core concepts like the no diet, why is it important post-transplant? Why taking minimum salt is important, because we found when they said no salt, patients were just cutting off salt from the diet completely. So no salt, the benefits of taking no salt, and such small little key pointers were important to educate the patient, because we thought educating the patient would be the easiest way to empower them to take decisions rather than follow a protocol, which is very common what we do. We realize that patients do here in India. And we also, in the book, we also concentrated on every nutrient and how is it important on the journey of chronic kidney disease, so that patients would know how to calculate their nutrients on their own and not be dependent in case they don't have the financial help to go and meet a renal dietitian or don't discuss this with their doctors. Until 2017, very interestingly, the book actually came together in September 2017 after a good 7 months, but it was based on the American System research. And suddenly we had the National Institute of Nutrition release a new finding on the Indian composition. So we called our renal dietitians back and we said, we're going to redo the book completely to suit the Indian compositions, because the book was dedicated to Indian patients. So the book was redone completely in 2017, and further flow chart was made so that this information was beautifully delivered to the patients. And finally we launched, can I have the book please? Can I have the books? Finally, we launched the Nutritional Secret in the year 2019. So when the Nutritional Secret books were launched, we were still not happy. This is the book that's going to be still available. When the book was launched, we were not yet happy, because we wanted the book to be available to remote parts of India, nutritional diets to be available to remote parts, because it's so important. We further translated the book into 8 different languages, regional languages, so it's available in different parts of the country. We further went on to do further discussions, and the year 2022, we released the Nutritional Secret Healthy Recipes for Chronic Kidney Disease, and this is one of the largest selling books online, and this is a book with the largest collection of Indian recipes, completely based on Indian composition tables, calculating every micronutrient. And the best thing is the recipes are really, really yummy. It talks about our very own grown flavors that we can eat in our country. And well, we also talk about some yummy pizzas if you want to still have it. But mostly we aimed at using what is available within our country. Thank you. We are very proud to actually say that we have taken the country forward with the work that we've done on renal diet, and we continue to do this work. And currently we are on the mission of actually working with renal dietitians and working with doctors to have more faith on renal dietitians and the role that they play in empowering the patient to live a healthy quality life on the journey of CKD. We also work with the dietitians who want to go into renal specializations. We give them training with our renal dietitians who are already specialized with us. And this is the way moving forward. And we aim to give back more to the patient community, because at the end of the day, we all agree that chronic kidney disease is lifestyle management, and it all starts with eating well and eating healthy. Once again, I'd like to thank Dr. Suganya and all the members of the committee for giving me this opportunity. It's such an honor, and it's also a very emotional moment for me to see so many people doing so much of work on renal diet, because I'm also a caregiver to my husband who had 2 transplants and also had an aortic dissection, which is 2 open heart surgeries. So this is a topic very, very close to us. So on behalf of the patient community, a special thanks to each one of you doing some amazing work in empowering the patient on this journey. Thank you.
I now request Dr. Sudha, Head of Department of Pediatric Nephrology, to felicitate ma'am. We've now reached the end of the inaugural ceremony. Let us now rise together for the national anthem. Once again, thank the dignitaries on stage. We now disperse for the tea session. Please assemble back by 11:25. Tea will be served just outside the auditorium.
So first of all, just to start off with, why is providing adequate nutrition so important in children with CKD? Well, as we've heard a little earlier from the nutritional assessment talk, the infantile phase is when growth is most rapid and is predominantly nutrition dependent. And if there's anything that interrupts that nutrition in the first year of life, particularly in the first 12 weeks of life, it has very long-term consequences in that linear growth is affected. The maximal growth after birth is in the first 12 weeks of life. And amazingly, if you just try to imagine this, that by the age of 2 years, a child will have attained about 50% of their adult height. So you can see if there's a disruption in their nutrition in that first year, it is going to have an impact on their height potential. We also know that these children have abnormal body composition in that they have a high fat mass and a low lean body mass, and they have increased central adiposity, which predisposes them to cardiovascular disease in later life. And we also know that they have a low ratio of length of their trunk to their limb. So these children, one of the reasons that's why they are short, because of that disproportion there. We know that if you have good nutrition early in life, that this can contribute to better cognitive outcomes. And we also know that many of these children with chronic kidney disease have developmental delay. Now, is that due to the age of onset of the CKD? How long they've had CKD? Is it associated with comorbidities? These are questions we just don't know the answer to at the moment. But that period of vulnerability to interrupted nutrition is extended in CKD. Again, we heard from the last speakers that the infantile growth phase of growth may be extended from 1 year up to 2 to 3 years. So these children have a nutritional vulnerability for much longer. It's not just the first year of life, it can be up to 2 to 3 years of age before they go into the childhood phase of growth. And another added complication is that many of these infants are born small. And indeed, in this review we did of retrospective review of 101 children we saw at Great Ormond Street, and these are children who are in end stage in the early months of life. 26 of them were premature, 18 were small for gestational age, and 10 were both premature and were small for gestational age. So you can see they're small babies just to start off with. So what are the consequences of them not getting nutrition? Well, of course, their growth becomes static. And this growth chart that you can see here, going quite that far, the growth chart that you can see is very typical. This is a growth chart of a boy who was born at 36 weeks gestation. And you can see even by 10 weeks of life, he's well below the 0.4 centile for both his weight, his length, and his head circumference is just about clinging onto the 0.4 centile. And that's because if there's inadequate nutrition and the weight and length of the child, of the baby is static, for just 2 weeks, they don't gain any weight. For 2 weeks, they drop 1 centile. If their weight is static for 4 weeks, they've dropped 2 centiles. So those first 12 weeks are very important because once you've lost those centiles, it's very difficult to give adequate nutrition to get the baby back up onto the centile you hope they would be growing along. Of course, growth does decelerate during the first year of life, but even at 26 weeks of age, if weight is static for 3 weeks, they lose a centile. And after 40 weeks of age, then it takes 4 weeks of static growth to lose yet another centile. So you can see these babies drop off their growth centiles very quickly. So most of what I'm going to say is going to be taken from the paper that we published in Pediatric Nephrology a couple of years ago now. And so these are our clinical practice recommendations from the Pediatric Renal Nutrition Task Force. So what are the energy requirements for children with CKD? Well, 4 trials have looked at resting energy expenditure and basal metabolic rate by indirect calorimetry, and they've found that there's no difference between the energy requirements for healthy children and those with CKD. So children with CKD don't need more, provided you've adjusted for their lean mass. And again, there have been observation and retrospective studies have shown that dietary intakes in children with CKD, which were about 100% of energy requirements, then this gave acceptable growth, whether these children were conservative managed or whether they were on PD. A large prospective trial of 51 children in the UK showed that these kids had normal growth with a median energy intake, again, around normal requirements, 94 to 98% of estimated requirements. And even at 2 years follow-up, they were still growing well on about 90% of normal healthy requirements. So it just shows us that they don't need a huge calorie intake in order to grow. So our recommendations are is that the initial prescription for energy intake in these babies and children should approximate that of healthy children of the same chronological age. What are the protein requirements for this group of children? Well, not very much work has been done on this. There are two rather old studies, which were randomized controlled studies. The first one from 1991 showed that children given a low protein diet, and these were all infants, had a lower standard deviation score for their length and growth velocity if they were given a low protein diet. However, a later study showed that in 226 children who were given the lowest safe protein intake had no difference in their growth compared with those who had an unrestricted protein intake. So a more recent Cochrane analysis, meta-analysis, has said that there's some uncertainty over the possibility of harm that's associated with a low protein diet. But the view of our group on the Nutrition Task Force was that we know from our own experience that a low protein intake increases the risk of malnutrition, protein energy wasting, and poor growth. And so we recommend that generous protein intakes are given. So what are the current recommendations for energy requirements for healthy children if we're saying that CKD children match these? Well, we looked at many international recommendations from all of these organizations you can see here, from the WHO, the USA, the UK, Nordic countries, Australia, New Zealand. And what we found that all of these countries in their published data for energy requirements, and this is for healthy children, all had, they were all given different titles, daily energy requirement, estimated average requirement. But what was more important is that the values that they gave for growth in normal children were quite different. So for example, in a 2-month-old baby, the USA recommends they need 95 calories per kilo per day, whereas the UK recommends 120. So which of those values should we take for the child with CKD? Similarly, we looked at all of the published recommendations for protein intake, and these were based on nitrogen balance studies using linear regression and taking into account nitrogen losses and the extra protein needed for growth. And again, all of these organizations describe protein intakes in a different way, but again, the values were quite different. And I've given an example here of a 3 to 5 month old baby. The Health Council of the Netherlands recommends 1.4 grams of protein per kilo per day, whereas the French recommendations gives a very big range, much lower at 0.9 grams and much higher at 2.6. So which of these values should we use, which are correct? Well, we opted to take a pragmatic approach and took the average of these national recommendations to give our recommendations for CKD. And we've come up with a novel term called the suggested dietary intake. So these are the average of the values given in international publications. And energy requirements fall at the top of the normal curve. So our suggested dietary intake, if a child is taking that amount at the top of the curve, then 50% of children will be getting enough energy. Some children will need more, some children will need less. When it comes to protein, then we want to have a safety net. And the SDI is down here at the tail of the normal curve. And that's the average amount plus 2 standard deviations. So if a child is taking the SDI, then we can reckon that nearly all the population, 97.5% of the population, will be getting adequate protein. And we would like universally for people to use the SDI so that when we're doing future research studies, we can actually compare studies because they'll all be using these standards. And the SDI can be used for formulating of dietary prescriptions and also assessing the adequacy of the diet of individual children. So let's just have a look at the energy requirements from birth to 12 months. So the figures that you see in the column here, we give a range. And so to the initial prescription for energy for a baby that's just born will lie somewhere between 93 and 107 calories per kilo. So that's a good starting point. But if we want to promote optimal growth, then we suggest that the energy intake is shifted towards the higher end of that range. And we heard in our earlier talk about using height age. If a child is below the 3rd centile for their length or height, then we recommend that we take their energy requirements for their height age. So for example, if you've got an 8-year-old child and they're only the size of a 5-year-old child, you would look at the energy requirements for a 5-year-old. If you try to feed them like an 8-year-old, you'll be trying to get so much nutrition into them, you're never going to achieve it, and you'll be overfeeding them in any case. So height age is like a proxy, if you like, for the size of the child and what their energy and protein requirements are. There are just a few things to note about energy intake, that if children are on peritoneal dialysis, then they'll be getting about 8 calories per kilo per day from the dialysate glucose, but that obviously depends on a number of factors like the glucose concentration of the dialysate, the length of time on dialysis, the number of cycles, etc. These can be a useful source of calories for children who aren't growing very well, but at the other end of the extreme, if children are gaining weight too rapidly, you need to take into account those calories from the dialysate and accordingly reduce the energy that you're giving them from their diet. But you'll hear more about that a little bit later. These are the protein requirements for the first year of life. And again, we've given an SDI, which is a range. The protein intake at the lowest end of the range that you see here, so for a newborn baby, 1.52 kilos, that's the minimum safe amount that you can give the baby. Don't reduce below this level, otherwise you're going to inhibit their ability to lay down lean tissue and therefore to grow in length. If a child is showing persistently high blood urea levels, you can adjust the protein intake towards the lower end of the SDI, but first you need to make sure, are there other reasons why they're running high urea levels? For example, are they on steroids? Are they acutely or chronically dehydrated? Or are they indeed catabolic? So the first thing to do is to make sure they're getting adequate energy. And when you've improved their energy intake, you may find that their urea levels come back into the normal range. But do be aware, if you have a child who's constantly running very low urea levels, we'd never expect a child with CKD to have normal urea levels. If they're showing urea levels less than the normal range, it's a pretty good indication that you're not giving them enough nutrition. They're being starved of protein. So that's an indication to increase their protein intake. Again, just a couple of alerts about dialysis, that there are protein losses during peritoneal dialysis. And I've just put here the KDOQI recommendations for additional protein that you need for losses on PD and hemodialysis. But again, you'll hear a bit more of that later. I've simply put here the SDIs for energy and protein for children up to 18 years of age, and all of those provisos around the edge are the things that I've just already spoken about. So as well as publishing our clinical practice recommendations, we've also translated those papers into a guide for healthcare professionals. And these energy and protein requirements in a very practical nature can be found on the website that I've given there. It's run by one of the feed manufacturers called VitaFlow, but they have no input into the dietary recommendations that we make. They provide an educational grant so that we can produce these nice glossy leaflets. Don't worry about reading the stuff on the right-hand side. I've just put that there as an example of the sort of information that you'll find in this practical guide, but I'll be working through this now. So what to feed the infant? Let's start off right at the beginning. Well, breastfeeding is the preferred method for feeding the baby with CKD, as for any other child in the population. And this concurs with the Cochrane review that WHO did. And breastfeeding exclusively is recommended for children with CKD up to 6 months of age, as per the normal population. But of course, we need to recognize that there's much individual variation. And so it's our job to do our dietary assessment to make sure whether we need to make changes according to the child's needs. If breastfeeding isn't possible, then we encourage the mother to express her breast milk, and Roshan will be elaborating on that much more when I finish speaking. And if breast milk isn't available or they're in adequate amounts, then we recommend weight-dominant infant formulas, and I've listed ones which are commonly available in India. These are also called stage 1 milks, and these have a nutritional profile the closest to breast milk. But of course, you don't get the bioactive factors like growth factors, hormones, enzymes in these infant formulas. That's only to be found in breast milk. But our challenge, as we all know, is poor growth in these infants with CKD. And again, here's a very typical growth chart for a child I've just put on the right-hand side here. And they're prone to vomiting because they have gastroesophageal reflux. They have delayed gastric emptying and gut dysmotility because we know that they don't clear polypeptide hormones like gastrin and cystokinin because of their poor kidney function. And they have high levels of circulating cytokines like leptin and ghrelin, and these all affect the satiety center and emptying of the stomach. So we want to try and optimize nutrition in the face of this poor growth that we're challenged with. And so we recommend to fortify breast milk and infant formula if infants are reluctant to give complete feeds, as they often are. If they're on a fluid restriction, then we need to concentrate the energy and protein we're giving them. And sometimes they just need higher nutritional needs to get them growing along their centile and not to start falling off and failing to thrive. So we can fortify expressed breast milk, and we can do this by adding the infant formula, the whey-based infant formula. And I've just given some calculations here, so you can see how we can improve the nutritional profile of breast milk by adding some infant formula. By adding 3 grams of infant formula powder, you've increased the energy density to 84 calories per 100 mils. And when you get up to 6 grams, you've got a 1 calorie per mil feed. And this will really give the child's nutrition a good boost. But do just remember that if you're concentrating feeds, you're also giving more phosphate, more potassium. And so that might just become a problem, but we'll just deal with energy and protein for now. For preterm infants, their breast milk can be fortified with one of the human milk fortifiers that I've mentioned here, and you need to follow the manufacturer's instructions about how to do that. So in order to get more nutrition into a given volume of feed, we can concentrate infant formula, and we can do this by gradually increasing the amount of powder we give to put in a given amount of water. So most infant formulas at a concentration of 13%, 13 grams of powder per 100 mils. And we can gradually either go up by 1 increment or perhaps more rapidly until we get up again to a 1 calorie per mil feed, which is your 20% feed here at the bottom. You can't see this, can you see this now? This slide has just shown a gradual increase in the amount of powder we're adding to 100 mils of feed. And then once we're up to a 20% solution, we're giving a nice 1 calorie per mil feed. But we do need to be careful because as we're increasing the concentration of the feed, we're increasing its osmolality. So that a box on the right-hand side is showing you how the osmolality of the feed increases as you start to concentrate it. We don't know what the upper level of tolerance is. It's probably about 500 milliosmoles per kilo. But as you start to increase the concentration of the feed, you can induce an osmotic diarrhea. The baby may vomit more. You may worsen their gastroesophageal reflux, which are all going to be counterproductive. So you do need to do this concentration very gradually. And also, as I mentioned before, as you concentrate a feed, you're going to be given more phosphate, potassium, and also vitamin A, which is something that we don't want to give excess amounts for in these children. You might sometimes find it useful to just add energy to a feed. If a child is catabolic, they're running high urea levels, it may just be because they're getting inadequate energy. And so sometimes it's a good move just to add some energy to the feed. And this can be done with glucose polymers if you have them. The advantage of using glucose polymer is that it's 6 glucose molecules joined together, which has a very low osmotic effect. And in fact, some work has done that if you add 2 grams of glucose polymer to 100 mils of feed, you only increase the osmolality by 31 milliosmoles per kilo. But if you don't have glucose polymer, then you're looking to use glucose or sucrose. But we don't really know for sure how much of these you can add without giving the child an osmotic diarrhea. But we do know because glucose is a monomer, sucrose is a disaccharide, they're going to have a much greater osmotic effect. And so you won't be able to add such a large amount of either sugar or glucose to a feed without perhaps giving the baby diarrhea. And of course, the intense sweetness of sugar may just make the baby refuse to take the feed in any case. We can also use fat as a source of calories. And again, if you've got fat emulsions, which are produced commercially, they can be added. But if you don't have those available, then you can add other oils. And whether it's best to add polyunsaturated oils or monounsaturated oils, very little work has been done on that. But we do know that if you add 2 mils of one of these oils to 100 mils of formula, it has very little effect on the osmolality, but it will settle out. If you're using a commercial formula, it's a fat emulsion, so it doesn't settle out, it just disperses into the feed. But if you're adding oil, it will separate out. So whilst feeding the baby, you need to stop and give the bottle a good shake very frequently so that the oil goes back into the feed and it's not just left lining the bottle and the baby doesn't get those calories. Some work done by Agarwal at the beginning of the 2000s, they added 2 mils of coconut oil to 100 mils of breast milk, and they found that there was very little change in the osmolality. Breast milk osmolality is about 300. It's not constant, it changes. But the problem adding fat to a feed is that it may delay gastric emptying, and we already know these children have delayed gastric emptying. It may make them nauseous, it may increase vomiting. So again, if you're adding carbohydrate or fat to an infant formula, it needs to be done gradually so you know at what point you've tipped over into that area of counterproductivity where you've made the baby vomit more, and then go back one step. So what about solid foods? Well, complementary feeding, of course, we want to encourage these babies to feed by mouth, but this does present challenges in that we know that acidosis, anemia and uremia have a negative influence on nutrition if they're not corrected. We know that children's appetite for both feeds and food for older children are impacted if they've got persistent gastroesophageal reflux and gut dysmotility. We heard a bit earlier that older children have reduced smell and taste sensations, and there's no reason to think that an infant's appetite might also be affected by this reduced sense of smell. Polyuric infants drink litres and litres of water. They preferentially drink water, which of course is going to fill them up and will reduce their appetite for their feed and for their foods. And also these babies will be on a whole range of medications which will further affect what they're prepared to put in their mouths. If they're having 4 or 5 nasty medicines in their mouth, how are they to know that when the bottle comes along, it's a nice tasting milk that they really ought to have? So you can see that all of these will impact on how much nutrition a baby and a young child will take. So let's hope that we can get some solids into babies. And what do we offer? Well, solids that should be introduced, as I said earlier, as recommended for healthy infants, but of course take into account the baby's cues and oral motor skills. And as these infants do have a degree of developmental delay often. They may not be ready for solids until much later than 6 months, but equally they might be looking and interested in food earlier, in which case there's no reason not to try. But we do need to encourage a progression of textures, that they don't get stuck on pureed foods, so that they progress on the texture, the thickness of the food, so they learn to chew and bite, and that the content varies as well. Because we know that if children have puree, there's a delay in exposing them to textured foods, it can cause later feeding problems. And I'm sure we've all seen 1-year-olds, 2-year-olds even, who are still stuck on eating pureed foods because they just don't want to chew and swallow anything more solid. We recommend a healthy, balanced diet with a wide variety of food choices. And again, you'll hear a bit more about this from Roshan. But again, we do just need to take into account that there might be some dietary restrictions, for example, phosphate and potassium, but we won't discuss that now. So we want to get the family as well as the baby used to a healthy, balanced diet, because the CKID study has shown that older children with CKD, these were children with mild to moderate CKD, and it was an older age group of children over 2 years of age. They have very undesirable eating habits with a preponderance of fast foods in their diet, which obviously is a major contribution to sodium, phosphate, and unsaturated fat intake, which isn't good for their long-term health. And I have to say, I have been rather disappointed as I've been going around town and that to find Burger King and McDonald's and KFC and Pizza Hut. So I know that fast foods are becoming a feature of the more traditional diet here. We don't want to have restrictions on a baby's diet unless we absolutely need to, because a more liberal oral intake will encourage more normal development and behaviours around food, so that hopefully we're not seeing children just pushing their head aside every time food comes near them, but they can sit at the table with their family and eat, not under pressure, but just take what they like and become more attuned that feeding and food can be something pleasurable and not something that your mother or your father is just pushing into you all the time because they know you've got to grow. If children are having inadequate dietary intake, first of all, we need to look at any medical causes that can be corrected, because there's no point us wading in with all of our nutritional interventions if there are things that we can do to help the gastroesophageal reflux, like giving alginates, antacids, H2 receptor antagonists, PPIs, prokinetics. Feed thickness is on the list here, and I don't know if any of you do thicken feeds, but in my experience, it doesn't help at all, because these children's gastroesophageal reflux isn't anatomical. It's not because they have reflux because they're on a thin feed and therefore thicker feed will keep it in their stomach. The reason why they have the gastroesophageal reflux is because they've got these high circulating levels of polypeptides and the cytokines, which affect the normal peristalsis and emptying of the stomach. So thickening the feed is not going to make any difference. If they're acidotic, then that will need to be corrected with base, because that's going to affect their intake. If they're volume overloaded or have inadequate dialysis, those need to be addressed first before we launch in with our nutritional interventions. Having done all of that, though, we want to start some oral nutritional supplementation, and we should be very prompt in acting when we do this. So as soon as we notice that there's a deterioration in the weight centile, we need to take action, whether it's a baby or a toddler or an older child. And we need to start oral nutritional supplementation as soon as we can. So again, for the babies, we can concentrate their feeds as I've described, or we can add infant formula powder to express breast milk, encourage the mother with her breastfeeding, and again, we'll hear more in a moment. Encourage high energy foods, but try and offer foods with a high nutritional value, not just going in with sweets and sugary foods. And to fortify foods as well, so we can add vegetable margarines and oils to savory foods. Again, it would be good if we could use oils which are rich in omega-3 fatty acids for their long-term cardiovascular health. So that's things like soya, walnut, and linseed oil. Or you can use olive oil, which is high in monounsaturated fats. And if you've got other oils available, corn, rapeseed, safflower, etc., then they can be used as well. So we've got a hierarchy, if you like, of the sorts of oils we should be adding. Sugar, jam, syrup, glucose can be added to sweet foods, and also you can add those to drinks as well to improve the energy intake. Again, I'm not expecting you to read this, but just to say that in the practical guide, we have got a list of high energy, low protein foods, which are useful to be able to supplement a child's diet. And I hope one of our longer term projects will be able to have an Indian version of this, and we'll be working on that. And there's also in the practical guide a list of high protein foods, because again, I'm talking about increasing energy, but to get a good balanced diet so that the baby can and children can lay down lean tissue rather than just fat, we need to ensure there's adequate protein as well. So these are exchanges of protein that might be added to the diet. And again, future work will be able to have a version of this which is suitable for foods that your children here are eating. So if there's insufficient intake to meet nutritional requirements, when we've done all of that lot, we've concentrated feeds, we've fortified foods, we've fortified drinks, our resort then is to initiate tube feeding. And that's something that we do very commonly in Europe and North America. And Roxana will be talking to you about tube feeding a little bit later today. So here are a few questions just to see if you have taken in anything of what I've just said in the last little while. This is one of your voting opportunities. So to promote optimal growth, what are the energy and protein requirements for children with CKD? Do they need 50% higher energy and protein than the requirements for healthy children? Should we aim to give energy and protein towards the higher end of the SDI? Do we want to reduce their protein intake while maximizing their energy levels? Or can their growth be maintained on less than 80% of normal energy and protein requirements? So over to you. Fabulous. Most of you have given the right answer there, that to promote optimal growth, we need to give them energy and protein intake towards the higher end of the suggested dietary intake. We don't want to reduce protein intake in these children unless they are really running very high urea levels, because some of these children will be taking protein that's higher than the SDI. That's not a problem in itself if it's not making them uremic. If they're getting adequate energy, they should be able to cope with a higher protein intake. But also just remember that children who have a high protein intake are almost certainly having a higher phosphate intake again, which may become problematic. So if you're on a dietary assessment, a child is taking more protein than the SDI, there's no reason for you to reduce it to become within the SDI if it's not causing problems. But what we don't want to be doing is giving these children a low protein intake, because if we just push calories into them, they're just going to lay down fat, they're not going to grow in length, they're not going to lay down lean tissue. And your next question, many factors affect a child's dietary intake. Which of the following statements isn't true? Acidosis, anemia, and uremia do not influence oral intake. A child's appetite for food may be impacted by gastroesophageal reflux and gut dysmotility. Older children have reduced smell and taste sensations. Multiple medications may affect what the child is prepared to swallow. So one of those statements is false. Which one is it? Excellent. Acidosis, edema, and uremia do influence oral intake in a negative way. A child's appetite will be impacted by reflux because they will have that horrible acid feeling all the time and their stomach doesn't empty normally. So gut dysmotility obviously affects their appetite for food. Older children have reduced smell and taste sensations, and that affects how well they eat. And as we mentioned before, the multiple medications that they have just makes everything in the mouth taste horrible, and so that affects their willingness to eat. So these three conditions, acidosis, anemia, and uremia, do influence oral intake and need to be corrected before we can be successful with our nutritional management. Okay, we're going to go straight on now to Roshan, who's going to talk about a much more practical approach of supporting a breastfeeding mother and illustrating some case studies.
Thank you, Vanessa. So after that excellent presentation where we learned so much about what needs to be done, let's try to see how we do it. So as we all know, attention to nutrition during infancy is important, given that growth is predominantly nutrition dependent in the infantile phase, and the growth of infants is acutely impaired by disruption to the nutritional intake, particularly during the first 6 months. Inadequate nutrition intake can result in failure to achieve full adult height potential and an increased risk for abnormal neurodevelopment. This is basically re-emphasizing what Vanessa just mentioned. So the guidelines regarding breastfeeding and complementary feeding are based on those given by the WHO, infant and young feeding practices. So breastfeeding by the biological mother is beneficial to infants, especially when they are preterm or compromised, as the mother's milk is specified to the needs of her infant. However, if it is not available, donor human milk and formula may be considered as an alternative. Very commonly, we see in Indian scenario that cow's milk is the preferred choice because it is easily available and more cost effective, but may not be an ideal choice. In a reference study compared to breastfed children, never breastfed children had smaller kidney volumes and lower estimated glomerular filtration rate at school age. These results suggested that breastfeeding is associated with subclinical changes in kidney outcomes and hence the importance of breastfeeding during infancy. So this is a chart which is normally given for an infant, but is as good applicable to an infant with CKD. So how and what and when do we do the feeding? So for an infant who is born at more than 36 weeks of gestational age, what should be given? It is breast milk. How? By direct breastfeeding. It can be started within 1 hour of birth and breastfeeding can continue every 3 hours or on demand feeding. For infants born at 32 to 36 weeks of gestation, breast milk or expressed milk or suckling directly from the breast is the choice. It can also be used in other way by giving a cup or a spoon or a palada feeding in addition to the feeding at breast. This may be required because the baby may not be able to suckle for a longer durations or may not be strong enough to suckle directly at the breast, and a little assistance in the form of a cup or a spoon feeding may be beneficial to increase the intake. Babies born before 32 weeks of gestation need to be given expressed breast milk. It can be administered through an intragastric tube because most of the times the oral feeding may not be an option here. It should be started 12 to 24 hours after birth once the baby is settled, and feeds can be given every 1 to 2 hours depending on the sugar levels and other conditions. How do we start with that? So for encouraging and optimizing breastfeeding, the first step to ensure that the infant gets what he needs in terms of nutrition. Breastfeeding forms part of a sustainable food system. While breastfeeding is a natural process, it is not always easy. Mothers need support both to get started and to sustain breastfeeding. Improving access to skilled counseling for breastfeeding can extend the duration of breastfeeding and promote exclusive breastfeeding. And here where dietitians and nutritionists can play a role, because we know that there's a dearth of dietitians in our setup, plus finding a lactation consultant is even more difficult. And usually the nursing staff are the ones who help the mothers to get the breastfeeding going. So if the dietitians can be of help, we can have a program where the breastfeeding is easily started and sustained for the infant. Supporting breastfeeding is for a healthier planet. Breastfeeding provides every child with best possible start in life. Breast milk is a natural, renewable food that is environmentally safe, produced and delivered without pollution, packaging, and waste, and is available to every infant. A few tips to encourage mothers to improve their breast milk supply. First, include plenty of water and fluids in the diet. Why this is important? Because many times the infant with CKD would be a sick baby and either in an ICU or some intensive unit. The mother would usually be stressed and not taking care of herself, thereby affecting the milk production. So while you're taking care of the infant, also please give a glance as to what is happening with the mother. Support her, counsel her, make sure she gets her nutrition proper so that the supply of milk can be sustained for the baby. Get enough rest, eat a balanced diet, high in proteins. This again becomes difficult when the mother is with the child in the hospital and the food is not allowed from the home. And in traditional Indian homes, there's a lot of traditional foods that go, which are not available to the mother. And she's too stressed to eat normally. Include galactagogues like the shatavari kalp, oats, wheat crack, fenugreek seeds, moringa or drumsticks, poppy seeds, fennel seeds, dry coconut, almond, etc. in the diet for the mother. Okay, these are things that will promote with the breast milk production. Nurse more frequently. It is said that the frequently the mother feeds the baby, the milk flow will continue better. Skin to skin contact with the baby also helps to produce more oxytocin production and thereby the best milk flow. Hot compressions over breast helps emptying of the breast properly. Now this is important, as we all know that the initial milk which is coming is basically the foremilk, and the next round of milk which comes is the hind milk. The hind milk is higher in fatty content and other products, and this will give the much needed energy boost that the baby requires. So counseling the mother to feed from one breast completely at one time and then moving on to the other breast is very important, that the child gets the best nutrition from the breast milk available. Next step is to establish proper breastfeeding. Like the figure 1, which shows good and poor attachment. This is the view you will get from external side, where you see the first picture showing that the areola is completely in the baby's mouth, thereby the breast milk flow would be excellent. The other picture shows that the baby is latched on only to the nipple or the teat, thereby the flow of milk will not be adequate. So the signs of poor attachment are more of the areola is visible below the baby's bottom lip than above the top lip, or the amounts above the and below are equal. The baby's mouth is not wide open. The baby's lower lip points forward or is turned inwards. The baby's chin is away from the breast milk. So these does not give good attachment and the breast milk will not flow smoothly. On the other hand, good attachment will have these 4 signs. More of the areola is visible above the baby's top lip than below the lower lip. The baby's mouth is wide open. The baby's lower lip is curled outwards. The baby's chin is touching or almost touching the breast. So if you can supervise the mother when she is breastfeeding in the initial few days and guide her with simple practice of getting good attachment, then it will really help with the production of breast milk. Alternative methods of feeding breast milk may be required for infants with CKD who are sick. So cup feeding, spoon feeding, syringe feeding, lactation aids, finger feeding, and paced bottle feeding are alternative feeding methods that allow oral supplementation of the baby who is unable to obtain a sufficient amount of breast milk from the breast. For most babies, these are temporary measures, and the ultimate goal is to establish feeding at the breast. Basically, what I am trying to tell you is they do whatever it takes to encourage breastfeeding of the sick infant. So let's have a poll question. Exclusive breastfeeding means that an infant receives, choose the correct answer. Option 1 is only breast milk from his or her mother or a wet nurse, only expressed breast milk and no other liquids or solids, only breast milk and no water with the exception of oral rehydration solution, drops or syrups consisting of vitamins, minerals, supplements or medicines. D, all of the above. Great. So we almost have it correct. All of these mean that is exclusive breastfeeding. Moving on, complementary feeding. So the energy required by age and the amount of breast milk shown in this column, in this table shows that as the child grows beyond 6 months of age, the gap between the required nutrients and that is received from the breast milk is increasing. So we have to ensure that at 6 months of age, the complementary feedings are started so that this gap does not increase or widen more. At 12 months, between 12 to 23 months, the gap for all the nutrients, as you can see, energy, protein, vitamin A is huge. Iron is a huge gap because, as we know, breast milk is very low in iron. Hence, complementary feeding needs to be started at 6 months of age. Here are a few guiding principles for complementary feeding of a breastfed child, especially the one with CKD or any other illness. So practice exclusive breastfeeding from birth to 6 months of age and introduce complementary foods at 6 months of age while continuing to breastfeed. That is more important. Continue frequent on-demand breastfeeding until 2 years of age or beyond. Practice responsive feeding, applying the principles of psychosocial care. Practice good hygiene and proper food handling. Start at 6 months of age with small amounts of foods and increase the quantity as the child gets older while maintaining frequent breastfeeding. Gradually increase food consistency and variety as the infant grows older, adapting to the infant's requirement and abilities. Increase the number of times that the child is fed complementary foods as the child gets older. Feed a variety of nutrient-rich foods to ensure that all nutrient needs are met, that is, following your balanced diet principle. Use fortified complementary foods or vitamin mineral supplements for the infant as needed. Increase fluid intake during illness, including more frequent breastfeeding, and encourage the child to eat soft, favorite foods. After illness, give food more often than usual and encourage the child to eat more. This will again, there will be a disclaimer about the fluid intake or requirement of the child depending on the CKD condition. So basically what it means is that you take care of the volume of feed, the frequency of feed, the texture of feed, and you progress as the baby grows older. Quality, frequency, and amount of foods for infants. So this chart shows the SDIs for energy and protein and how do you manage to get it in an infant's daily routine. So for 6 to 8 months, you need to give 200 kilocalories per day additional to the breast milk. You can start with thick porridges, well-mashed foods, around 2 to 3 meals per day besides breastfeeding. Depending on the child's appetite, you can add 1 or 2 small snacks in between. That will be in the weaning food forms. Start with 2 to 3 tablespoons per feed, increasing gradually to half of a 250 ml cup. From 9 to 11 months, you give 300 kilocalories per day in addition to the breast milk. This is the time when you can add finely chopped or mashed foods and foods that a baby can pick up. 3 to 4 meals per day in addition to the breast milk. Depending on the child's appetite, 1 or 2 snacks may be offered. Half of a 250 ml cup or bowl should be the target that we reach by this age. Around 12 to 23 months, 550 kilocalorie per day in addition to the breast milk calories and nutrients received. Family foods, chopped or mashed foods if necessary should be added at this time. 3 to 4 meals per day depending on the child's appetite. 1 to 2 snacks may be offered, and 3/4 to full of the 250 ml cup or bowl is the target that the baby should receive. So as the baby grows, we are going to reduce the quantity and frequency of the breast milk that is provided and increase the solid oral foods much more.
Roshan, can you provide another 50 minutes?
Yes, ma'am.
We are really running short.
Yes, ma'am. So these are a kind of a case study I have put. So baby A, age 5 months, 16 days, weighing 3 kg, was on direct breastfeeding plus EBM of 25 to 30 ml every 3 hourly, providing 156 kilocalories and 2.64 gram proteins from the EBM. Intervention was done where half a scoop of Dexolac high-cal formula was added to the EBM in all feeds and was provided. This provided additional 132 calories and 3.4 gram of proteins, giving total 288 calories and the 6.05 grams of protein, plus what the baby got from direct breastfeeding. So the addition of a supplement, as Vanessa had explained to us earlier, showed a weight gain of 0.200 kgs after 3 days of intervention. This may appear really minuscule, but is a big step for the increasing the weight and the intake of the child. Case 2, age 5 months, 10 days, weighing 6 kg, was on exclusive direct breastfeeding. Started with 30 ml weaning feed of rice moong dal powder cooked in water with 1 ml MCT oil, and 3 feeds of this were given in addition to the breastfeeding. This provided additional 55 calories, but the baby showed a weight gain of 0.300 kgs after 1 week of intervention. So gradually, we increase the number and quantity of the weaning feeds to match the SDI. So we see that the supplementing and fortifying can help with the increasing the nutritional status or improving the nutritional status of the infant. Coming to complementary feed, I'll not go into the detail. Basically, as I explained earlier, you need to include all different kinds of foods so that the nutritional requirement of all nutrients are met. A good complementary feed will be rich in energy, proteins, micronutrients, will not be spicy or salty, will be easy for the child to eat. So the consistency has to match with the requirement of the child. It can be soft, blenderized, thin, thick as per the child's requirement. Locally available and affordable foods should be included. Some of the examples of low-cost nutritious supplements. You have to ensure adequate nutritional care of the infant by giving traditional infant feeding practices with enrichment of the food with nutritious food available in the household. Choose wisely quantities of the amount of food to be given from the family pot. Examples are wheat flour and gram porridge, rice and green gram and nuts porridge, millets porridge, rice khichdi's, malted grains or millet porridges. These are the different, there's a huge range of weaning foods that you can ensure to give the baby, and little help to the mother can make sure that even if the baby who's in CKD has restrictions of phosphorus and potassium and other stuff, you can guide as to which food grains to select to give the minimum potassium phosphorus if there is a restriction. So you have to be mindful of that when you're planning the weaning foods for the babies. So the question, let's have another poll question. WHO has given guiding principles for complementary feeding of the breastfed child. Which of the following statement is incorrect? Practice exclusive breastfeeding for birth to 6 months of age and introduce complementary foods at 6 months of age while continuing to breastfeed. Continue frequent on-demand breastfeeding until 2 years of age or beyond. Third, stop breastfeeding once complementary feeding is begun. Increase the number of times that the child is fed complementary foods as the child gets older. So which of the statement is incorrect? Great. So we all know what we have to do. a few seconds here on the slide. Basically, we know that most of the Indian foods are vegetarian protein source, or there may be situations where we cannot give animal protein. So how do you ensure that your baby's diet is having adequate, good quality protein? Basically, you know that one of the amino acid is lacking in grains and another is lacking in pulses and dals. So where we complement both these foods, we can ensure that the biological value of the food is improved. You can also combine the legumes with the grains or the legumes with milk products, and that way enhance the quality and the quantity of proteins in the infant's diet. Soy is another source which can be added to a vegetarian protein source. Summarizing, ensuring protein and energy adequacy is important for growth and appropriate weight gain in an infant with CKD. Breast milk is best for the baby. Establishing breastfeeding in a child with CKD may be difficult, but with support, this can be achieved. Fortify breast milk and supplement with complementary feeds to meet the SDI for energy and proteins. Low-cost, nutritious complementary feeds can help to meet the nutritional requirements of an infant with CKD. Protein demands can be met with vegetarian sources of proteins like dals, pulses, nuts, and soy. Combining grains with pulses and dairy can help to improve the biological value of proteins from vegetarian sources. Thank you.
Thank you. For the enlightening talk and lot of practical points that were being discussed. For one of them, we will keep the questions to the end. And let me now invite Dr. B.P.R., Associate Professor of Pediatric Nephrology, Christian Medical College, New for a talk on energy and protein required menstruation situation.
Good morning, all. Thank you, Sukanya ma'am, for the opportunity. Before starting, I would like to think of remember my chief, Dr. Indra Agarwal madam, who gave me the opportunity to be a part of this project. I'm quite happy today that my all-time mentor and my professor in pediatrics, Dr. Susan ma'am, because of whom I have become a nephrologist, is chairing my session. Thank you for your all-time mentorship. My topic will be energy and protein requirements in special situations, dialysis, proteinuria, and obesity. Dialysis in children. How is the scenario different when children are on dialysis? Peritoneal dialysis and hemodialysis are associated with significant protein losses in the dialysate or filtrate. Secondly, the children on peritoneal dialysis, there is extra energy intake from the glucose containing dialysate, which should be considered. This had been already emphasized by Dr. Vanessa. Peritoneal dialysis is associated with protein loss, and which is higher losses in smaller children. So infants have around 0.3 and adolescents have around 0.1 gram per kg per day and 6 to 8 gram in adults. The nutrition prescription of protein must take into account the mode of dialysis, the peritoneal transport status, and increased protein losses during peritonitis. And hence protein intake should be increased above the SDI by at least 0.15 to 0.3 in children on PD and 0.1 in children on HD. And the amount of glucose absorption depends upon the glucose concentration of the dialysis, which may be 1.5 or 2.5%, the dwell times, the number of cycles, the time on dialysis, the peritoneal membrane transport status. And the PD glucose may augment the calorie intake by around 7 to 10 kilocalorie per kg per day. It's roughly around 50 to 150 gram of carbohydrates from the dialysate. About the protein requirement, an objective measure of the dietary protein intake in stable patient receiving maintenance hemodialysis, as Aparna ma'am told, is PCR, which which can be normalized for the weight and is known as normalized PCR. This was initially studied in 1980 as a marker of dietary protein intake in pediatric HD patients, and Kedoki mentions to do a monthly assessment of NPCR for maintenance HD patients. In children with CKD 5D, it is suggested to maintain a dietary protein intake at 100% of the dietary requirement for the ideal body weight plus the allowance for the losses. There is no clear evidence that routine nutritional supplementation have similar effect in older children, though it is quite helpful in younger children and infants. But no study has demonstrated a growth advantage to a calorie intake greater than the 75% RDA, which approximates to around 100% of the expected energy requirement. The recommended protein intake for a CKD stage 3 is 100 to 140%. As we move on to CKD stage 4 or 5, it is reduced a little bit to 100 to 120% of the recommended dietary intake. In hemodialysis, a little bit more is added, and for PD, there is an added 0.15 to 0.3 gram per kg per day. And you can see the requirement is more in younger children. How do we go about a stepwise increment of energy intake during dialysis? Vanessa madam had already spoken about it. These would be the steps in which we would increment the intake and the prescription of calories in children on dialysis. Initially, the energy intake prescribed should exceed the RDA for age, at least initially. Then go about increasing the energy supplements to achieve a higher RDA as per the chronological age if children are malnourished. If there is no weight gain in spite of doing this, the recommended energy intake can be based on the height and age, so that we augment the prescribed calories. In spite of doing all this, if the child doesn't gain weight, oral intake can be given with energy dense diet or fortification, as was already mentioned. Next step would be to give commercial nutritional supplements to support the supplementary nutrition. If the child fails to meet his or her energy requirements through food and fluids alone, or if the child is not achieving expected rates of weight gain or growth for age. Further step would be to include, to introduce tube feeds or gastrostomy feeds if the child still has a under nutrition in spite of doing all this. Last step would be a trial of intradialytic parenteral nutrition to augment the nutritional intake, especially for malnourished children with a BMI less than 5th percentile receiving maintenance hemodialysis who are unable to meet their nutritional requirements through oral or tube feeding. The other, never forget about the other spectrum of malnutrition, which is obesity. Definitely dietary and lifestyle changes have to be advised if children are obese while on dialysis. What about the electrolyte requirement? Supplementary free water and sodium supplements are required in two conditions. One is when children are polyuric, and second is infants with CKD who are on chronic peritoneal dialysis. Restriction of sodium intake when children are hypertensive or pre-hypertensive. Fluid intake is restricted when the children are oligoanuric and there is to prevent the complications of fluid overload. Potassium intake is restricted when there is hyperkalemia. Roughly, energy requirements during childhood are neonates 100 kilocalorie per kg per day, and it decreases as age progresses, reaching puberty to adulthood around 50 kilocalorie per kg per day. Whereas older adults, it will be 35 to 40 kilocalorie per kg per day. Accepted macronutrient distribution within the calorie intake would be carbohydrates around 45 to 65%, fat around 30%, and protein around 10 to 30%. That's about children on dialysis. Going ahead with nephrotic syndrome in children. Nephrotic syndrome is characterized by edema or anasarca with nephrotic proteinuria, meaning to say they lose a lot of proteins in urine, and hypoalbuminemia where the serum albumin is very low, and they are usually associated with hypercholesterolemia. What are the aspects which need attention when prescribing a diet for nephrotic children? We need to address edema, proteinuria, hypoalbuminemia, and hypercholesterolemia. When there is edema, we tend to take care of the fluid and salt When there is proteinuria and hypoalbuminemia, how do we go about prescribing their protein intake? And when there is hypercholesterolemia, how do we maintain their fat intake? So this is how a nephrotic child will look like. 3 to 8 years, early morning puffiness, later anasarca, and a decreased urine output. So more than calorie and protein, we'll be very much worried about the fluid prescription for the children. Nephrotic syndrome with persistent edema needs a strict fluid prescription with daily strict intake, output, and weight chart, fluid restricted diet. Initial days of admission, because we don't know how much urine the patient will pass, we usually prescribe 2/3 or half the daily maintenance fluid requirement. Holiday cigar formula helps us in calculating the daily maintenance fluid for a child. It goes like this: 100 milligram per kg for the first 10 kg, then 50 milligram per kg for next 10 kg, and 20 milligram per kg for the remaining weight. So for example, for a 30 kg child, calculation according to the holiday cigar will give us 1700 ml per day. And initial days, we tend to give either half of this or 2/3 of this. Second formula is the 4:1 formula, where milligram ml per kg per hour, which is an hourly infusion, is calculated. This also, for the same 30 kg child, if you calculate, you get kind of the same fluid requirement over a day. So maintenance fluid in a proteinuric edematous child can be any of these three, depending upon which day of admission or how many days of edema, and depending upon the urine output of the child. So initially it should be 2/3 to half maintenance. Further, when you are able to quantify the urine output daily, then add on to the previous day's urine output the insensible water losses. And in older children or adults, we usually prescribe 500 ml plus the previous day's urine output. This is for children who are oliguric and their urine output is less than normal. And insensible water loss, rough calculation is 20 to 30 ml per kg per day or 400 ml per meter square per day. And they need diuretics when indicated. One extra thing we do in Vellore is, because it's quite summer and very hot, we sometimes give 600 ml per meter square per day in hot summers. This is the insensible fluid loss. You can see preterm infants or neonates have a little higher insensible fluid loss, 40-30 ml per kg per day, whereas children, adolescents, and adults have around 20 ml per kg per day or 400 ml per meter square. I remember there was a question in the keypad. What are the fluids in which are considered as to be fluids? Which are the foods which are considered to be fluids? Any food that is liquid at room temperature counts as fluid, which can be any of the milk products, ice cream kind of stuff, soup, pudding, fluids in any of the gravies. Helpful. So when we advise the parents, this is one of the extra thing we tell, that it's not only water, it includes all the other food which can be liquid at room temperature. Helpful hints for restricting fluid intake for children are using smaller glasses for measuring fluid intake. Instead of giving them water in 250 ml, give them water in 50 or 100 ml. Avoid salty food as they increase thirst. Allow child to rinse the mouth with cold water but not to swallow. Sucking on a lemon which can stimulate saliva and moisten the mouth. Staying out of sun to prevent thirst on hot days. And splashes of cold water on child's face and body help them cooling. Helpful hints again, thirst is better quenched when iced tea is used with lemonade, frozen pieces of fruits, and chewing gum or hard candy. These are kind of fooling the child and helping the mother. So nephrotic syndrome, what about the protein and calorie intake? A balanced diet with dietary recommended intake of protein of normal protein and calorie intake is given. Avoid sugar-rich food and animal fats to reduce the weight gain, especially because they'll be on prednisolone. High fiber diet so that they can reduce the calories to avoid a weight gain because of the steroid intake. Albumin infusion when indicated. Additional protein intake is needed in persistent massive proteinuria for prolonged duration, like when etiology of the nephrotic syndrome is membranous nephropathy. Salt restriction until the child is edematous. Most salt restricted diet has 1.5 to 2 gram per day. Avoid all added salt at the table. Avoid foods high in sodium. Use low salt or non-salt seasoning. Over restriction of sodium in these children can lead to excessive tiredness, convulsion, and shock. I think I won't go into much details of salt because Meenakshi ma'am is dealing a whole lecture on salt in children, salt and how to give a salt restricted diet. These are the following foods which are high in sodium, like most of the canned processed salted cheese, butters, and all the fried snacks. And alternate low sodium seasonings are most of the spices, tamarinds, and lemons. So to summarize the nephrotic syndrome diet, in children with edema, we tend to look at the fluid and salt and give a restricted fluid prescription if the child is edematous, restricted salt when the child is edematous, protein intake when they are proteinuric and hypoalbuminemic, but it is given as normal recommended daily allowance of protein and calories. And hypercholesterolemia, fat intake can be restricted to avoid the excess sugar-rich food and animal fats to avoid a weight gain. Coming to obesity, according to the classification, overweight is more than 85th percentile and obesity is more than 95th percentile. Sure, ma'am. Sure, ma'am. Message on this. Sure. Definitely. Thank you so much. I'm sorry to interrupt you. No problem. So now we have 3 minutes for any questions for all 3 of you. Anyone from the audience? Okay, yes, please. Yeah. Please,
to all the speakers for the excellent presentation. My question is to Mehta. Ma'am, I want to know if you have already found maltodextrin to be used to concentrate the energy of the kids. Maltodextrin.
Yes, maltodextrins can be used.
Because they don't want us
it's the same principle as I was describing for glucose and sucrose, that if you're using monosaccharides, disaccharides, they create a great osmotic effect. Maltodextrose will be somewhere between that and using a glucose polymer. So maltodextrose can be used and it will have a lower osmotic effect than if you're using a monosaccharide. So yes, it can be used, but it does need to be used in a gradual manner so that you can see the point where you might have overdone it to the child that's and be up to formula or drinks.
Perhaps how to change the family diet so that the young child incorporates a good healthy diet. Vanessa, theoretically, what changes, what simple changes to a family diet, and Roshan, how would you implement that?
I think it would be to educate the family on foods of high nutritional quality. So the first thing would be to take a dietary assessment of how the family is eating, and then to identify the foods that you can replace. The important thing is when you're doing these replacements, make sure you're preserving the energy protein intake, so that if you're asking the family to change from one type of food to another, they're not suddenly getting a drop in calories or a drop in protein.
I think practically it can be done, it will have to be done twofold at the same time. One is to making foods which are empty calories and no nutrients, which are generally stored in our households. Just open the tin and it's really available. So you make that redundant and replace it. Maybe some suggestions as to how it can be replaced with ready to access, readily accessible foods which are much more nutrients.
Absolutely. Thank you very much. It's the processed foods that are taking over. Thank you for that. So I'm really sorry to say that I have to stop this symposium now. It's really interesting, but there are all the workshops tomorrow cover a lot of the practical aspects. I'm sorry to stop you, but then a lot of the content will be covered tomorrow. Thank you all very much. Thank you. We now move on to the next session, calcium and phosphate prescription by Dr. Manisha and Dr. Arpana. I request moderators to introduce speakers.
So, good morning and thank you for this opportunity. So, I'm the one between, I'm an adult nephrologist. It's very easy that it's suggested to others, but I really enjoy my one max with the pediatric nephro as well. So, I am not watching to stick to that nephro. But still, I'm really happy I'm handling both predominantly, I'm really happy. So, going over to the introduction of Dr. Nancy. She is currently PGI at the prestigious PGI. She did her doctorate degree in nutrition from the same institute. She is a registered dietitian, experience of 22 plus years. That's a huge experience. And you can see her major achievements, gold medalist, course of dietitian from North India, course of dietitian for 5 year diet study, several honors and awards and multiple publications. And we'll be happy to move on to a session that's calcium and phosphate prescription, dietary assessment of the training. Over to you, Dr. Nancy. Excited to hear you.
Thank you so much, and thanks organizers, especially Dr. Sukanya, to have called me over here. And I'll be talking about dietary assessment of calcium and phosphorus. Now, dietary adequacy of both calcium and phosphorus, as you all know, is an important part of CKD management because deficiency of both can lead to mineral and bone disorders. And on the other hand, excess intake of calcium and phosphorus is also detrimental because it leads to nephron calcineosis and vascular calcification. Now, the tools for dietary assessment of calcium and phosphorus have been beautifully actually already explained by Dr. Meenakshi. There's a 3-day prospective dietary food recall, food frequency questionnaire. I'll just skip these slides because there'll be a repetition. And 24-hour recall, we actually use this 24-hour recall, to rapidly estimate calcium and phosphorus intake. Because this is a detailed dietary assessment, she's already covered this. And of course, we are all running short of time, so I'll just skip these slides. Now, the thing which I would like to emphasize is that the tools that can assist in estimation of portion sizes. This is very important, as Dr. Meenakshi also put it, that the person who is taking the diet recall has to be empowered nutritionist actually. He or she should have a full knowledge of, analyzing the portion sizes what the patient is having, like teaspoons and tablespoons. And of course, if these are available in the market, but then you can tell the patients that they're household measures. Then again, the models, slices, pictures of chapati, you should have an idea. Then handfuls, for example, this handful of raw rice is 20 grams. So you should know if a mother tells you कि इतना चावल बनाया था, so it is equivalent to 1/4 cup raw rice or 1/3 cup cooked rice. So this knowledge, the person who is taking the interview should have. Then again, cups, these cups are available in the market. Then beakers, and again, like you should know the equivalent of the household measures, like the ladles. One ladle, if somebody says, I had a ladle full of dal, so you should know that it is equivalent to 80 ml, or maybe one household katori, or 16 teaspoons or whatever, or one household soup bowl is equivalent to 150 ml, or 100 ml is equivalent to half cup, 200 ml is equivalent to 1 cup. So this is very important. A more detailed account of frequency of consumption of specific dietary sources of calcium and phosphorus can be asserted by direct questioning. Anything which you feel that it can be of help in questioning, we'll talk about it later.
Then of course, they will be converted into weights and used, all the portion sizes which you have, they all will be converted into weights, and then you can calculate them. So trained interviewer is required in diet history. This is a crux of everything, which has been actually discussed in the morning. So coming to the points to be considered while taking dietary assessment, all sources of calcium and phosphorus in diet as well as enteral nutraceutical prescription or infant formula should be documented. So you need to be aware of everything, that everything has calcium and phosphorus. All sources of calcium and phosphorus in medications, dialysate, phosphate binders should be documented. Now, the facts about calcium assessment is that calculated estimates of dietary calcium intake using a nutrient database and dietary assessment software packages are considered reasonably accurate. International data suggests that dietary products are the largest contributor of calcium intake in most children. And in early infancy, breast milk or infant formulas comprise 100% of the daily dietary calcium intake. And the milk and milk products, they contribute to 44 to 70% of dietary calcium intake, whereas cereal and cereal products contribute to 16 to 18% to 28% of average dietary calcium intake. This is according to this table. This is a National Diet and Nutrition Survey done in London. Whereas in India, it can be a different story. Like, in rural areas, more than 80% of kids, they have less than 50% of recommended dietary intake from milk. And similarly, this table also shows, this is from urban Western Indian children, that it is 53% of recommended dietary allowances, and from this 30% calcium comes from milk. So, all the areas of India, they vary in the resource of the calcium intake. Then another fact, hard water from taps and from some mineral waters can be an important source of calcium, with bioavailability similar to the dairy products. Like, for example, in Punjab, in Nawashahar, it is like 50 milligrams per liter. And now new guidelines from FSI push all packaged water manufacturers to add 20 milligrams of calcium per liter in all packaging. So you need to be aware while assessing these intakes. Now this question, spinach is a rich source of calcium. What's the approximate bioavailability of calcium from spinach? It's 10%, less than 10%. So the bioavailability of calcium is below 10% for vegetables and fruits. So although some cereals and green leafy vegetables and fruits may be rich source of calcium, given the low bioavailability of calcium from these sources, children with CKD are unlikely to consume sufficient quantities in order to meet their nutritional requirements. Now, the efficacy of absorption is influenced by the phytate and the oxalate content, amount consumed, the vitamin D status. Then coming to the calcium guide, the guide to calcium content in cereals. Now, this I've calculated according to a portion size which a 5-year-old can have. And I've also calculated the bioavailability, but again, the bioavailability will vary according to the vitamin D status, according to the nutritional status of the child. So you see that this wheat flour has highest amongst all, and of course all these Kellogg's and all, they're all fortified, but they have a downside of having all the preservatives. Then coming to pulses, horse gram has this whole pulses horse gram is the richest one. Then soya chunk, soya bean. So you should have a fair idea. This is per portion I'm giving according to the kit. Then spinach, as we just mentioned, it is quite high, 83 milligrams per portion, but only, it is 10% bioavailability. But still, if you see, if the child has all these green leafy vegetables like, bathua or amaranth, still the calcium can be there, but then the downside is potassium. Now, calcium from breast milk and infant formulas has an absorption efficacy of about 66 and 40% respectively. However, as formulas have a higher concentration of calcium than breast milk, this comparison in bioavailability may not be important. Coming to milk and milk products, now curd is richest source, followed by buffalo milk. Then chicken wings have more. Then egg is also a good source. Then this white sesame seeds is a very rich source of calcium. 10 grams is 128 milligrams. Then jaggery, please do not, ignore these things, jaggery and all. They also have calcium. So my point of giving this is that you should be actually quite aware of everything, from where that calcium is going to come. Now again, the kids, these use Horlicks. It is 15-gram portion size gives 111 milligrams. Boost 15 grams gives around 86 milligrams. Bonvita 15 grams gives 15 milligrams. So this is important to know. So the absorption of calcium from foods and medications is about 30%, but varies between 5 and 82% depending upon the food source and subject-related factors, particularly their vitamin D status. And then calcium from all these binders. Calcium carbonate contains 40% calcium with an absorption of 20 to 30%, whereas calcium acetate contains 25% of calcium with an absorption of 20% when taken with meals. So to sum up, my next speakers, they'll be coming forward with the assessment part. So yeah, this is a summary of recommended dietary allowance. So we can compare it with this, that has the child taken at this level or no? Because in children with CKD stage 2 to 5 and 5D, it is suggested that total oral or enteral calcium intake from nutritional sources and phosphate binders be in the range of 100 to 2%, 200% of the DRI for calcium for age. So, now coming to the phosphorus assessment. Now, hyperphosphatemia and other factors play a major role in the development of cardiovascular events. Everybody knows it. Therefore, general approach to manage hyperphosphatemia is to restrict phosphate intake. The KDOQI guidelines recommend limiting phosphorus to 100% of age-related DRI unless both phosphate and parathyroid hormones are secondarily elevated, in which case the patient should receive 80% of the DRI. In all CKD stages, it is suggested to avoid serum phosphorus concentrations both above and below the normal reference range for age. Now, coming to the phosphorus facts, dietary phosphorus is available in two forms, organic as well as inorganic, with inorganic phosphates added during the food processing part. Now, a medium-sized roti, which is a staple of North Indian population, it gives additional burden of around about 80 milligrams of phosphate content, and even the dal, one of the primary protein sources, have phosphorus to protein ratio ranging from 14 to 18 milligrams per gram, though with lower bioavailability because of the phytate content. As with calcium intake, highest percentage intake of phosphorus comes from milk and milk products, and breast milk is relatively low in phosphate, having a concentration about half of most standard whey-based formulas and 1/3 of casein-based infant formulas. Now, plant milk and non-milk based puddings may be fortified with calcium phosphate. Then phosphate additives may be used in manufactured foods, but their use can increase phosphorus content by more than 50%. A diet using mainly fresh foods will contain a higher proportion of natural phosphorus, which has a lower bioavailability. So that is why we always, emphasize on fresh foods and homemade foods. Remember, manufacturers are not currently required by law to include phosphorus content in the nutritional information on packaging, and look for phos in the ingredient list of processed foods whenever you are assessing the phosphorus content. This indicates the presence of phosphate additives. Inorganic phosphorus are also added to antacids and antihypertensive medications. Now, gelusil and Diogen are free of phosphates. Now, the antihypertensive medications which have phosphorus are, like for example, lisinopril is 32.6 milligrams, and a generic 10 milligram amlodipine contains 40.1 milligram phosphorus, which is noteworthy. Now, nutrient database and dietary assessment softwares are used to assess phosphorus intake, but they do not include the amount of inorganic phosphorus derived from phosphate additives. Consequently, assessed total daily phosphorus intake in individuals and national dietary surveys may underestimate the true phosphorus intake by over 20%. And it is very true in case of children because they are more prone to having processed foods. So foods which may have phosphate additives, all these foods, they are definitely going to have the phosphate additives, and these are the name of certain phosphate additives, and you know, they are all put in colas or candied fruits or soft drinks, jellies, chocolates, even dehydrated milk powders, then in baked products, toasted barley, coffee, chocolate, and all these things. So in short, all the processed items, please look for the phosphate content. Now, foods with comparable phosphorus load, we have already discussed it, that if you compare the phosphorus of egg with cola, they are same with the face value. But when you see the bioavailability, it is only like yielding, the egg is only yielding 40%, whereas the cola, it is 100%, the phosphorus is available. So this is where we have to see what to choose for the child. Now, another question, cooking can leach out phosphorus from food. I think Meenakshi ma'am has already covered this. So the answer is yes. So another question, that which method is more suitable for same? If the answer is yes. Correct, it is boiling. So boiling reduces phosphorus reduction up to 51% for vegetables, 48% for legumes, 38% for meat, 70% for flour, but it is not practical for the flour, 19% for the cheese. But in case of vegetables, it is possible that favorable effect of phosphorus removal by boiling be partly counteracted by an increase in digestible phosphate derived from the phytate processing. This is a clinically and dietetically important knowledge gap that needs further investigation. Now, in a mixed diet, the phosphorus content has also been attempted to be calculated via certain equations. Now, you know, these are the three equations given by, Bose and Kalantar and Kubisti. But then the equation given by the first equation was found to be best fitting equation and explained 84% of the variance in dietary phosphate intake. But all said and done, importantly, these regression equations may underestimate the problem because nutrient database underestimates the phosphorus content of food by approximately 25 to 30%. Now, another question, cottage cheese has more phosphorus than milk. It is 328 milligram per 100 gram versus 96 milligram per 100 ml. Therefore, should milk be an option instead of cottage cheese in CKD stage 2 to 5 patients trying to control dietary phosphorus? Yes or no? No, that's great. So you know all. Why? Because you see, the cottage cheese, 35 grams of paneer is equivalent to the protein of 200 ml of milk. But then 200 ml of milk is giving you quite a lot of phosphorus as compared to 35 grams of paneer or cottage cheese, but with an equal proportion of protein. So definitely. And then there is always issue of fluid and volume restriction. So we can always go with cheese instead of milk. So on the we have not to see the things on the face value. These are high phosphorus, these are low phosphorus. We have to see their place value actually. So in cereals, again, all the cereals which are refined have low phosphorus content. And pulses, whole dals and washed dals, they have approximately equal amount of phosphorus content, with kidney beans and soya bean having more. Then milk and milk products, again, the phosphorus content I've given according to the portion size which child can have. So this is the way I have put it. So then non-vegetarian items, then all the organ meats like liver, mutton liver, chicken, poultry liver, you can see that it has the maximum phosphorus content. So that has to be avoided at any cost. But then again, one egg is like 103 phosphorus content, but egg white is very less. So we can always tell the kids to have egg white instead of egg. 2 egg whites is equivalent to the protein of 1 whole egg. So one can always do that. Then nuts and oil seeds, then you can just see, like for example, pista is richest in phosphorus. So you should know what to choose and how to choose. And again, the vegetables, all green leafy vegetables are low in phosphorus, but of course the potassium content is going to be a problem over here. So you have to think that how you can incorporate and in what quantity. Then if we see the phosphorus content of all the, these processed items, colas and Diet Pepsi, Lipton iced tea, Horlicks, Bonvita, it is quite a lot. Then the junk food, tomato ketchup. Kids love tomato ketchup with every, pakoda and every samosa. So tomato ketchup 15 grams is 4.4. So you should be aware of everything. So probe each and everything when you take a diet recall. Each and every small item matters. Then in these biscuits, you see one biscuit is 23 milligrams, and all this is available readily. Dark chocolate, it is rich in phytates, so hence low bioavailability of phosphorus. But in any case, we cannot, advocate these foods at any cost. Then jaggery, tamarind, but these are all the miscellaneous items. So my point of putting all this is that we need to actually count everything. For that, we cannot like any coconut chutney or tamarind chutney or jaggery put in milk or something. So you have to count everything. So to conclude, an effective and patient-friendly approach to reduce phosphorus intake without depriving patient of adequate protein is to educate the patient to avoid foods with high phosphorus relative to protein, such as egg yolk, as well as high amounts of phosphorus-based preservatives, such as certain soft drinks and enhanced cheese and meat. Phosphorus-rich foods should be prepared by boiling, which reduces phosphorus as well as sodium and potassium content, or by other types of cooking-induced demineralization. The dose of phosphorus binding therapy should be adjusted separately for the amount and absorbability of phosphorus in each meal, and dietitian counseling to address the emerging aspect of dietary phosphorus management is instrumental for achieving a reduction of phosphorus load. So this is a 24-hour recall form. Everybody is well aware of the 24-hour recall form. It's very commonly used everywhere. So, this early morning breakfast, mid-morning snacks and drinks, lunch, evening, dinner, before retiring to bed, medications or enteral nutraceutical formulas, infant formulas that can be included. Another form which can be included is like, this is biscuits type brand, household measures, weight, volume per day, per week. Per week, till per week it is okay, because you will come to know that what is the frequency of eating. If the child is having 6 times per week, it's almost daily. So, and calcium and phosphorus, so chips, namkeen, cold drinks, and all these junk items, sauces, and all these can be put up like this for the assessment. And last but not the least, then you have to, compare it with the suggested dietary intake of both calcium and phosphorus, whatever you are assessing. So suggested dietary intakes and all, they are coming up shortly. Thank you.
Thank you, Nancy. Presented information on calcium and phosphorus, giving us valuable practical insights. I think we will take questions in the end, and we'll quickly move on to a digital study by none other than Dr. Ruxana Shroff, who needs no introduction by now. And I think Dr. Ruxana and Annie, the nephrology dietitian combo, is going to portray a real-world experience of work culture, I guess, in day-to-day practice with each one of us. Dr. Ruxana Shroff is a pediatric nephrologist, a consultant, a professor in pediatric nephrology at Great Ormond Street Hospital for Children, London. Besides being a physician, she is an amazing researcher. She has won several grants to her credit. She is a great academician, not only to her community in the UK, but has been a mentor to many of us here in India. So, welcome, Dr. Ruxana Shroff, and thank you so much for initiating this unique program. I hope we really reach our goals. Annie is a bright and competent dietitian who was fortunately with us for a couple of years, and that's when we actually address nutrition care in our patients with CKD. So, over to you, Dr.
Thank you very much. So Annie and I are going to try and do a double act with this, with a little bit of theory and then some practical coming in together side by side. So without further ado, what we'll talk to you about today are the optimal requirements in CKD 2 to 5D, the management of calcium and phosphate in the diet, medications and dialysis, and a case study. We'll base our work on the guideline recommendations from the guidelines you see here, guideline committees you see here, and take you through this together. So in CKD-MBD, managing calcium and phosphate is a really tough balancing act. Too little calcium can cause bone pain, rickets, and osteopenia. Too much can cause fractures. Too little can cause fractures, but too much can cause vascular calcification, which in the end leads to cardiovascular mortality, which is the main cause of death. The KDIGO group have called this the CKD-MBD sort of triad. And really, we as the clinicians and dietitians are trapped on this balancing wire. So let's start with the first question. So a 6-week-old baby boy is diagnosed with posterior urethral valves. His creatinine is extremely high at 280 micromoles per liter, but his calcium and phosphate levels are still normal. And he has persistent vomiting and needs nasogastric feeds. So our dietitian Annie asks, how much calcium and phosphate would you provide in the feeds here? So let's move to this, this multiple choice question with your voting, and Annie's going to tell you how much to manage here. So, yeah. Sorry, I'm not reading it out for you, but you can see all the options here. So basically, this is comparing against healthy children. On the next slide. Before it.
Okay, the right answer is same as for healthy infants. I think, yes, we had 28% from the audience who gave us the right answer.
And these charts here just show you the daily calcium balance in the first year of life, and that it remains high until about the age of 4 years, then coming back towards the normal levels in older children and adults. And a similar thing is seen with serum phosphate as well, where again you have high requirements at birth coming down towards normal by about 4 years.
The reason for this is that if we look at this graph here, the calcium content of the bone is shown on the y-axis. It goes from just 25 grams at birth to as much as 1.5 kilograms in an adult male. And so you have a very rapid accrual of calcium in the first years of life, with this very steep peak, which then comes